Good afternoon, dear delegates, and with the divine blessings of His Holiness Jagadguru Shri Shivarati Deshikendra Mahaswamiji, Jagadguru Shri Veera Simhasana Mahasamsthana Math Suttur Shri Kshetra. Hereby would like to welcome all of you for the second day of India GCP workshop organized by the JSS Academy of Higher Education and Research, deemed to be university, and the JSS Dental College and Hospital, Institutional Ethics Committee of JSS Dental College and Hospital, Mysuru, in association with Yenepoya Ethics Committee 1, Yenepoya, deemed to be University, Mangalore. As most of us aware of, that yesterday afternoon, we conducted the first half of this India GCP program, in which the resource person, namely Dr. Veena Vaswani Madam and Dr. Ravi Vaswani and Dr. Uma Kulkarni from Yenepoya, talked on the topics like introduction to India GCP good clinical practice guidelines, important definitions, clinical trials, phases and types. They also spoke about components of protocol and protocol related documents, and also regarding ethics committee functioning, composition and the review process. Today, the second day, that is 28th, the same resource persons along with Dr. Pratibha Perera from CDSA CCRE JSS Hospital, Mysuru. Today we'll be covering the topics like informed consent process, including assent, vulnerability in research, serious adverse events and compensation, conflict of interest, then responsibility of sponsors, CRO and investigators, privacy and confidentiality, standard of care, data safety and management. And Dr. Pratibha Perera will be talking on new drug clinical trial rules, followed by question and answer session and the valedictory function. Now I hereby welcome our distinguished resource person for the day, Dr. Uma ma'am, Ravi Vaswani ma'am, Veena Vaswani ma'am, for this program. And hereby also welcome our beloved chairman, Dr. Vishweshwara sir, for this program.
In research. Okay. This is also again an important part of the GCP guidelines. It comes under point number 4.8. So we all know that informed consent has come a long way since way back when medicine started. So there was no informed consent process that was there. There was no concept of informed consent at that point of time when medicine was evolving. And there was a lot of paternalistic attitude where the doctors used to decide what is best for the patient, and it was always in the best interest of the patient. And at the same time, the patients were not permitted to decide for themselves that they want to undergo some procedure or they don't want to undergo some procedure. So it was purely left to the physician. And the same thing had continued in research also. And initially in research also, there was no informed consent. As we know, in many studies like Tuskegee syphilis trial, even in the Nazi experimentations, we had research being conducted on participants without any informed consent. But slowly things have changed, and the concept of informed consent is getting more and more respect, and people are following it in research, making research to be more ethical research. It's all based on the principle of autonomy, whereas where it says that every individual has got a right to self-determine, to decide for himself or herself anything in healthcare as well as in research. So that's the basis of informed consent. So the question is, does informed consent for therapy differ from informed consent for research? If a person comes to me, say if this is me, and this is a patient who has come to me for glaucoma checkup, and this patient has been my patient for the last 10 or 15 years. And today, suddenly, I have got a grant and I'm conducting a research on glaucoma. The same patient I'm evaluating now, but with the intent of research. So, does the informed consent for therapy differ for informed consent for research? And I'm sure most of you would have answers saying yes, they are different. Yes, they are different because therapy would mean that I have the flexibility to change the treatment that is required for this patient who has glaucoma. So today I give one drug and I follow the patient for a period of 1 month or two, and then I find that the intraocular pressures are not getting controlled, and then I feel, let me try another drug. So I have the flexibility to change the drug that is required for him. I can try out a different, even innovations I can try out in therapy. But in research, there is a strict protocol. If the research is on drug A versus drug B, I have to decide whether, if it is randomized, I have to say this particular patient will get drug A. That's all. The dosage is fixed as per the protocol. The follow-up durations are fixed, and how I change and whether I change the protocol all depends on only serious adverse. Only if there is a serious adverse event, then only I can intervene and make changes according to the protocol. Otherwise, I have to seriously follow the protocol and cannot have the flexibility in research. And therefore, when I'm treating this patient, say with laser, I take an informed consent for therapy. But this time, if I am doing research, then the informed consent for research has to be completely different. So I cannot use the same informed consent for both therapy and research. So that's about the difference between therapy and research when it comes to informed consent. So the next point, you guys have. So what is this informed consent? Most of the time we all have experienced that we have gone to the hospitals, even being doctors, we have gone to the hospitals, and when with our relatives or elders or some such thing, and when they say there's a surgery, please sign here. We just go ahead and sign. We don't even read what is written on the informed consent form. We don't read the policies of the hospital. We don't know what are the terms and conditions. We don't read the risk that is involved. We seem to have understood everything and we are ready for the procedure, and then we sign. That is not true informed consent. Whether it is in research or in therapy, the informed consent is completely different. It is a process. It is not a formality to be completed before a procedure. So it's a long process. It cannot be just, I give you all the information and you agree, or a brief interaction and then decision is made. Or sometimes even the patient might say, the participant might say that you decide, you are my doctor for the last 15 years. Now, if you decide to put me into research, it's your decision. I completely trust you. No, even that should not happen. The decision making has to be by the participant with complete assistance, information, and making sure that the participant has understood everything. The decision has to be made by the person, by the participant. So it's not just about signing the form. The second thing is, we often see our postgraduate students, particularly when they have a large sample size to be covered within a short period of time, they come and say that I'm yet to get 20 samples, ma'am, I'm not able to get. When we suggest that there is a patient, why don't you speak to him? Yes, ma'am, I will convince him. So it's not about convincing a person to take part in the research. It's not about convincing, it is about giving all the information and allowing that person to take a decision for his own. So that's very, very important to differentiate between consent and convincing the participant. So when the informed consent document comes to the ethics committee, what are the various components which are present there? One is the participant information sheet. Okay, so this is the information which is given to the participant to read, understand, and discussed with the researcher. Second is the informed consent form, which is signed, and a copy of this is kept with both. So this is the contract or the sign between the contract between the researcher and the participant, and this is the legal form that is kept by both of them. Then the translated versions of PIS and ICF. PIS is the participant information sheet and the informed consent form. So in Mangalore, we have we insist on at least 2 translations. One into Kannada, because a lot of people here coming from Kannada know Kannada. rather than English, and it's very comfortable for them to understand the information when it is given in Kannada. Secondly, since Mangalore is on the border of Kerala and Karnataka, we have a lot of patients coming from North Kerala to our hospital, and they can be research participants. Hence, we insist on at least 2 translations, Kannada and Malayalam. So depending on different places, they can have different languages into which the informed consent and the PIS are translated. Then we have something called back translation. The back translation is the translation of the translated version of the PIS back into English. We'll come to that in detail. Then the translation certificate saying that this translation is accurate and it is not misleading or misinterpreting. And lastly, the ethics committee approval for the same. In addition to this, when children are involved, you may require to add some more documents to it, and that includes assent form and next parental consent form. So consent form is now replaced by parental informed consent form and assent of the child. And next, when person is not able to give consent for himself, a surrogate informed consent form will be available. So those are in addition to these documents that the researcher submits to the ethics committee for approval. So we recently had a workshop on informed consent, and we wanted to include many of the students, researchers, and to make them understand what informed consent is all about. So we gave them an option of coming for a movie, and slowly, bit by bit, we gave them different informations. Like there's a movie, how many of you want to come? 70% said yes. It's a Marathi movie, so how many people would understand? So only 40% agreed. Then when we went on giving one and additional information one by one, the difference in the agreement percentage went on increasing every time. Each time we were giving an information, the numbers would either drop or would rise. So this indicates that every single information that is given to the participants to make a decision is important. You cannot exclude, and the final decision is not dependent on the last thing that you told a participant, but it's a cumulative decision based on all the information that you have provided. And therefore, it's very, very important to give every single information to the participant. This was a very good exercise to show how different components of the participant information sheet have an influence on the informed consent decision. So what are the components of informed consent? So informed consent has got 2 main documents, as we said. One is the participant information sheet. This is an information document which is given to the participants to read much ahead of time and understand what this all is about. This detailed information is a written document. It's not only an oral or verbal communication with the participant. It should be written in a very simple and clear language, a language which is understandable by an illiterate also. So even an illiterate person should be able to understand what is written. Therefore, we have to avoid any kind of scientific terms, technical terms, jargon, or sophisticated terms. Very simple language, as if you're speaking to your 7th or 8th standard child. It should be as simple as that. The translation should be in the local vernacular language. So the translation in Mangalore into Kannada might slightly differ from the translation that is adequate for Mysore, because the Kannada language in Mysore is quite different from the Kannada language in Mangalore. And therefore, small variations in the informed consent translations may be seen across different sites within the same state also. So sometimes it's very difficult. Suppose I'm doing a surgical intervention. It's very difficult for me to make the patient understand that this is research in which I'm trying a new technique of surgery, in which case I can use charts, models, videos, audios, or any form of audiovisual aid in order to make the participant understand what exactly is going to be done. So we often feel that participants are illiterates, they will not understand anything. Even if they are illiterates, they are not medicos, they will not understand what is inside the eye, where is the lens, where is the retina, where is the optic nerve, they might not understand, but we are underestimating them. It's always good to use these charts, models, or diagrams to simply explain everything to the participant and at least try to make them understand what is being done inside the eye, or whichever surgery or procedure you are planning to do as a part of research. It's also important to note that it's not just handing over that document to them, but we have to discuss it in detail. So every line, it's good to read loudly, make the participant understand, and then ask questions and discuss it, not just read it out or hand it over. It's always good to give one copy of the participant information sheet well in advance to the participant so that he or she can read it once, take it back home, discuss with family members, and then come back with the final decision. So essentially, the participant information sheet is like a mini protocol. A protocol is a huge document which has got all scientific terms, technical terms, the procedures, but informed consent form, the participant information sheet, will have a very small, like we used to have those huge Shakespeare books, and we used to have abridged versions. The abridged versions are the ones which are smaller, simpler stories, the same stories written by Shakespeare in the huge volumes in poetic language. So this is something like that for anybody to understand. It's simplified in very simple language, but the contents are all the same. This is what we discussed yesterday. So the contents remain the same, but it is simplified in a language that is understood. So basically, protocol is the one which is submitted to the ethics committee for approval. Similarly, participant information sheet is given to the participants for them to say, yes, this is okay for me. So this is the difference between the two. What should be the content of the participant information sheet? It should contain information about research. First thing important is to say that this is research and this is not therapy. Many times the patients, just like I said, 10 to 15 years if the patient is coming to me for treatment of glaucoma, one fine day, I decide to do research on the same patient. The patient should not be under the impression, 15 years she has been treating me. Now also, maybe it's a continuation. She's trying out new treatment on me. But the patient has to understand that this is research and many things are not clear about this intervention that I'm trying on the patient. The side effects may not be known, the efficacy may not be known, long-term effects may not be known, the correct dosage may not be known. So many things may be unknown about it. And it may happen that during the treatment, the glaucoma may worsen also because the drug may not be so effective. So it's important for the patient to understand that this is not treatment, but this is research. If the patient does not understand and joins the research thinking that this is part of therapy, then it is termed therapeutic misconception. Therapeutic misconception is very unethical if we allow it to do. So we have to take all the measures to make sure that the participant has understood that this is not therapy, but this is research. So we have to avoid therapeutic misconception. You have to tell about the researchers. See, I'm doing research because I am working on glaucoma for a long period of time now. I want to try out this research. I am the researchers. I'm qualified in doing this, and so on and so forth. So that the person also knows that whatever intervention is being tried on me is done by a qualified person. Same thing what the ethics committee is looking at. So patient also should understand that the research is being done by a qualified person, and therefore probably there is safety assured for me. Why this research is being done? So patient also, just like we give to the ethics committee saying this research is being done, need for the study and all that, we have to say that in glaucoma, many drugs are being tried, but optimum intraocular pressure management is not achieved with the current drugs, and there are side effects. So we are trying out whether this new drug will be useful in controlling the intraocular pressure with minimal side effects. So there are gaps in the treatment, and therefore we are trying to find the gap. So that will make it clear that, okay, this is research and there are problems in this glaucoma treatment. That is what they are going to find out. The person also should know what is the duration of participation. So some studies involve only one contact. They come, you take the data, and the patient goes back. So those are usually observational studies wherein you're not giving any intervention. It's their cross-sectional one-time studies. There, you can just say that the observation will be over a period of 15 to 20 minutes or whatever. Even in questionnaire-based studies, you can give a duration that you have to fill in this questionnaire, and you may take about 45 minutes to fill the questionnaire. So the duration of participation is important. In clinical trials, much of the data is collected in different intervals, and the patient has to come for multiple follow-ups. So the duration can be 1 year, it can be 2 years, it can be 5 years. In studies on long-term conditions like hypertension, diabetes, a follow-up may be for a longer period of time. So that should be known to the participant. So when it is clear, the participant can make a clear decision whether he or she wants to participate or not. Study site. Where is the study going to be conducted? Are the participants supposed to come to the hospital for each time for blood check or whatever tests are being done? Or are they coming? So there are community studies also where the researchers go to the community and give the details. So that also should be clear for the participants. On whom is the study being conducted? So if I have to say, I'll say to the participant that I am doing this study on all those glaucoma patients who are not getting control with the current line of treatment. So the person will know that, okay, there are many others like me, and how many of them also can be told, you are being involved in this study because your glaucoma is not getting control with the current management, and therefore we want to try new forms of treatment for you. Okay, and then also say what will be done. So am I giving a laser treatment? Am I giving a new medication? Or am I trying out a new surgery or a combination of these? How long am I going to do? All these interventions, including if there is a blood test which is going to be done, am I taking a sample from the eye and sending for histopathology or some genomic or proteomic study? Or am I just instilling drops? All this should be clearly laid out in the, just like the methodology of the protocol, it has to be clearly written in the participant information sheet. At this point, when the hall is filled with participants in GCP workshops, many of them raise their hands and ask questions. Will the participant understand everything? And that's what I say. We always underestimate them. We think we know. We think that we interpret it as they don't understand anything. But it's our duty to explain in as simple language as possible, even if it is a surgical procedure, with the help of some aid, make them understand, and then they can decide whether they want to agree or not. The next point is about responsibilities of the research participant. During the research, you're not supposed to wear, say for example, in the eyes, you're not supposed to wear contact lenses. You're not supposed to use any herbal medicines, because many people instill ghee or breast milk or cow's milk into the eyes as a form of treatment for chronic diseases. But if you are in the research, you're not supposed to do that. So it should be clearly written that during this research study, for the next whatever duration of follow-up that is required, you will not be instilling any of these herbal medicines in your eyes. So it's very important indication, responsibility of the research participant, because if they start using other medicines, then it can affect the results of the study. At the same time, the drug and whatever herbal medicine may interact and cause more complications to the participants. So it's very important for them to understand that they cannot mix up with any other therapy. At the same time, some clinical drugs which are given parenterally, the participants should make, especially the women, should make sure that they don't become pregnant during the study, because the drug is unknown. The side effects many of the side effects are not known. Many of the side effects could include teratogenic effects for the baby, and therefore it's very, very strictly to be understood by the participant that she cannot get pregnant during that research time. And what contraceptive methods have to be used, everything should be clearly written in the participant information sheet. So it so happened in our center that there was a study in which a male participant had taken part, and it was the first in human study, and the permission was given. But we came to know that his wife got pregnant and reported with a congenital anomaly. So it became very difficult to establish whether it is possible that if the man takes part in the research and his wife conceives and the child has abnormalities, can the drug be correlated with the possibility of congenital abnormality in the baby? So it was very difficult for us to decide the causality and relatedness of the intervention, and we had to unblind everything to find out whether the patient had received placebo or the drug under intervention. So it becomes a very complex procedure. It's always good to inform even the male participants that their wife should not become pregnant during that time, because sometimes some of the drugs may be transmitted to the woman through the semen also. That possibility cannot be ruled out, although it is very, very rare. So in research, these responsibilities are to be clearly written down. And the expectation, if we have clearly said that this is research and not therapy, then the patient should also understand that I cannot expect to be cured because of this new treatment, because many of the things are unknown. It can be efficacious, it may not be efficacious. So the expectation should be understood that whatever the drug is going to affect me, there is a possibility that I may worsen also, and there's also a possibility that I'll be cured. Both are possible. So the person has to know that both these possibilities can occur in him or her during the research. So every single information is therefore important. The other thing that should also include is benefits. Who's going to get benefit from the research? Is there any direct benefit to the participant? Most of the clinical research, there is no direct benefit to the participant. They are only there because lots is not known about the drug. If the person is very lucky, there'll be improvement. If the person is not so lucky, he may have serious adverse events or sometimes even death, because death also is reported. So it should be clearly written there that it is not directly going to benefit you. In fact, the benefit is usually to the PI, the investigator, because the investigators, they get the funding, the name, the institution gets funding and name, the institution gets a lot of points in NAC assessment, the investigator gets promotion, because once you do a research and publish, you go ahead in the ladder to get promotions also. MCI, DCI, they all ask for promotions, publications for promotions, and therefore the benefit is more to the researchers than the research participants in many of the instances. So that should also be known. You may not write that I am doing it because I will want promotion, but you can say that there is no direct benefit to the participants at least. Sometimes when you're talking about devices and you may come up with patents and there's a lot of financial implication, you can say there is a possibility that if the researcher is a big-hearted person, he might say that if I get a lot of money in this, I'll try to share the benefit in some way to the participants, not directly in the form of money, but at least in the form of service to the community from where the participants have come. Reimbursement. It's important to give reimbursement in sponsored clinical trials, because many times the patients have to come to the hospital several times, and they come from far off places also, and therefore reimbursement has to be given. So this reimbursement can be calculated based on the charges, bus charges from the place to the hospital, even including the auto charges if at all they are required. 1 day spent, that means 1 day wages lost. So that money can be included. 1 day coming here, and maybe they have to spend money for their tea, coffee, lunch. So that also can be included. So the reimbursement is all the actual expenses that have incurred during the visit, each visit. So each visit, this reimbursement can be done, and this should be written clearly, and the receipt should be submitted to the ethics committee for verification. So that's very, very important part. And this reimbursement should not be to the extent that it is likely to induce the participants to be participants of study. Suppose the expenses of coming from that place to here is around 100 rupees. So 100 to come and 100 to go back, 200, and 1 day expenses in the hospital, 200 becomes 300, and say loss of wages another. So it cannot be more than 600 or so. Suppose if you calculate and you say the total expenses or reimbursement is 600, but now you are willing to give some such amount like 5,000 rupees. okay, then there is a likely chance that the person, even if he is not so interested in the research and he has understood the risk, he understands that this is very risky, but he might come only because you are paying 6,000 rupees per visit. So that becomes an inducement. So inducement should be avoided in research, and whatever money is given should be equivalent to the amount that he would spend during the each visit. Next is community benefit. So in many studies, there can be a benefit to the community because of the intervention, nutritional studies, and some such diabetic studies, HIV studies, because we have seen previous HIV studies where the benefit was extended to the whole community, and therefore those can be included. Reminding the same HIV study, there were studies on HIV communities wherein HIV was very, very common. And after the study was completed, the HIV drug was available at a very high cost, which the community could not afford. And in such cases, it's important for the sponsors to think whether it is possible to extend the accessibility of the drug either free of cost or for certain lesser cost to the people so that they can afford for some duration of time till the government makes it available. So it's possible for the sponsor to again with a big heart decide that we will try to make this drug available if it turns out to be efficacious during the research to the communities from where the participants have been drawn, at least for a period of 2 to 3 years, till such time that the government is able to give it free of cost or at a subsidized cost. So that will be very good. And many times researchers, the sponsors may not be willing to do it so openly, and ethics committees may have to ask for it. The discomforts, including small discomforts like allergic reaction, local hematomas after blood drawing, should all be written, and also what protection from harm. So what precautions will be taken, even if it is of drawing the blood from the antecubital vein. There can be some discomfort, mild discomfort, right? There can be a hematoma. So you can say that blood will be drawn, about 5 ml of blood will be drawn from your arm, but at the same time we'll make sure that we'll take all the aseptic precautions so that you don't get any complications, and at the same time the blood drawing will be done by a qualified person. So this ensures that you are taking whatever protection from harm has to be done while drawing the blood. How will you manage the harm? Suppose there's a adverse event or serious adverse event or an anaphylactic reaction. You can say that we have facilities in the hospital as well as expertise in the hospital, and we'll handle them in our hospital in case there is any serious event that occurs as a result of research. And we will be managing the harm by giving free services for any complication that may arise during the study. So it's very, very important. So either like how we discussed yesterday, either you have some insurance to pay for such expenses, or the hospital has to have some corpus or indemnity to handle such a harm that can occur in research. And lastly, compensation. So compensation needs to be written in all clinical trials, the details of compensation, and this is what the lawyer member of the ethics committee will look into, whether the compensation is as per requirements or not. Yeah, this I already said. Even when blood is being drawn, how is the blood and from where is the blood being drawn? How much blood? Because sometimes if you say 10 ml of blood will be drawn, patients may not understand, your participants may not understand how much is 10 ml. So you may have to say, okay, 2-3 spoons or whatever number of spoons of blood equivalent to so much will be drawn to make it simple. How many times? We had a study in which a premature baby was being involved in the study, and they said we are taking 2 ml of blood. And when we went through the whole protocol, in the participant information sheet, they had clearly written 2 ml of blood will be drawn. And then when we saw the protocol, every day they are going to take 2 ml of blood for the next 15 days to do some analysis and see serial changes in the blood levels of some marker. And then we said that means if every day blood is being drawn, the total number of blood times the blood is being drawn is so much. So when we asked them to include in the PIS, the researcher said if we say that we are going to take 2 ml of blood from a premature baby every day, the parents are not going to be willing to allow the blood to be taken for research. And therefore, we don't want to say, we'll say that it is part of the daily. We said, no, that is cheating, that cannot be done. It has to be clearly laid out in the participant information sheet. And the parent should decide only based on all the risk put together. And you cannot misinterpret anything. So they included, they were able to complete this project. Hopefully they have done a good informed consent process. Also include who will be taking the blood, a qualified person. When you say that a qualified person is taking the blood samples, there should be no problem. And also tell about the mild discomfort. Also include everything about what you are going to do with the blood samples. For example, are you using it for this research, and what tests will be done? Will it be stored for some duration of time? Some researchers are very willing to store the blood samples for 5 years or 10 years and say that we want to reuse these blood samples for future studies, especially when the target population is cancer population, where they are afraid that they might not get the numbers. So it's very important to clearly write in the participant information sheet that we'll be storing your blood samples for 5 years. For what? That also should be written. Are you going to share it with somebody else? Like, for example, I want to share it with a US-based company which is doing genomic studies. So the patient should know, before enrolling for the study, they should know that the blood samples are going there and some genomic studies are going to be done. They may not understand everything, but it becomes our duty to make them understand that what is genomic study and what can happen when there is a genomic study on the blood samples. Are they being reused for future research? And how and when they will be disposed. These are important components that need to be written. For this, to understand why these small things are important, it is important to understand the HeLa cell lines, the story of Henrietta Lacks, which is very, very important for us to understand. So if we get time towards the end, we will speak about it. You know that blood samples have the genes and therefore it can be identifiable. So it's something identifiable, especially when you do a genetic study, and therefore it's very important to mention about privacy and confidentiality, not only when it comes to blood samples, but also any other data being collected during study. So you might have their detailed information, you might have the address collected. And so how are you handling their privacy and confidentiality? No individual's privacy should be encroached or confidentiality should be breached during research. We often take photographs during treatment to show before and after effects. It's important to mask the photographs in such a way that their confidentiality is assured. So many times we use these research findings in presentations, in conferences, or even for publications. And at that point of time, it's important to make sure that it is written clearly in the participant information sheet that your photographs will be used for research, for presentations, and for publications. You can even show them the photograph, get their approval before using them for presentation. The choice they have to participate or to refuse to participate, or even to take a U-turn, that is even to withdraw from the study after saying yes once, is theirs. And that is the whole concept of informed consent, because we want to respect the autonomy. So they have the choice and they should know that they have a choice. So many times they don't know that they have a choice. They think whatever doctor is telling, I have to say yes. I have to say yes for everything, but that's not true. You need to tell them clearly. It should be written clearly in the PIS that you have a choice to refuse to participate. You have a choice to say no right in the beginning and later on also from the study. And that there's no force or coercion. There's no limitation of your rights. So your healthcare rights will not be affected if you say no or if you withdraw from the study. You have adequate time to decide. So it cannot be that today morning is the laser procedure I want to do on my patient. 15 minutes before that, I take a research consent. That is not acceptable, because the patient will not have time to decide whether he or she wants to become the research participant or not based on the risk. So you have to give adequate time. This adequate time is not defined by anybody, neither by the guidelines, nor ICMR guidelines, nor by the GCP guidelines. Nobody defines it. It depends on the research, the nature of information that is given. So I would say that for a questionnaire-based study, which takes some information about how they felt after the procedure or some such thing, you can even give it half an hour or 20 minutes before that. But if it's an intervention, give at least 2 to 3 days time for them to understand, consult somebody, then come back and say yes or no. So that adequate time is again to be decided by the researcher. If there's any doubt in the mind of the researcher, of the research participant, there should be adequate time to clarify those doubts. It should not be in a hurry. And also for any problems related to research, the ethics committee member secretaries or the chairperson's phone number and details should be given for contacting. So most of the PIS in our hospital will carry our names and phone numbers. So these are something that is important. Also, in the responsibilities of the participants, you should also include that if they have these reactions, like adverse reactions or any such complication in the period during which follow-up is in between the follow-ups, they have to immediately report. They should not wait for the day of follow-up to come back with saying that 10 days back I had this swelling, now it is not there. Then you will not be able to evaluate such events. So it's very important. After giving all this information, you have to make sure that they have understood this information, which is very important. So you can start your KBC, ask certain questions which are most important for decision making. You can have an MCQ type or an open answer question, and then give it to the participant. So at the end of it, participant will mark everything and give the answers to you. You can assess whether he or she has adequately understood or not. If not, you can repeat the process. And that's the reason informed consent requires a lot of time to give all the information for them to understand, to make sure that they have understood, clarify the doubts, and then make a decision. So that's one thing that you need to do. So the importance of translation in a small example. So in the participant information sheet, it's written, we will inform an operation on the eye or whatever in detail, okay? We will, so when we translate into Kannada, I hope most of you know Kannada, so I'm using this Kannada translation. It got translated as now Karyacharaneyannu madutteve. Now Karyacharane is a different term when it is coming to operation. It is like Operation Blue Diamond and Operation something, which is there in administrative processes. Whereas this operation, what I mean in research is the medical operation or the surgery, right? So it's giving a wrong meaning. So if you only translate and give it back, give it to the participant, it may not actually mean what you want to mean. And therefore, you have an additional step to make sure that your translation is accurate, and therefore you have a back translation. When you back translate it, you get this answer. When you convert this Kannada into again English, translate it into English, you get this. We will conduct an event. Oh, now you know that this operation word has been wrongly translated as Karyacharane, which got back translated as an event, and ultimately this English document and the back translated English document do not match, do not mean the same. The meaning is changing here, and therefore this can get rejected. Therefore, you need to retranslate into Kannada, and when you retranslate using either changing this word or changing this word, now Shastra Chikitse Madutteve. Now when you back translate, we get the correct meaning. And here what we mean is we will perform an operation which is getting translated as we will conduct a surgery. Although the words used are different, they are meaning the same thing. So only when the back translation is same as the primary English document, you get a acceptance and certification for that. And therefore the documents which we listed in informed consent document are the participant information sheet, the translation, the back translation, and the translation certificate. So translation is usually done by people who are trained in that. There are people who are doing medical translation in research. There are many online services also which are available, and they also have a certification person who will certify that the actual English document and the back translation are meaning the same. So only when that is certified, it is given to the ethics committee. So if everything is done, what is the role of ethics committee? So this is one example. If one of the lines in the English document in the PIS is the following tests will be conducted, that is HB1AC, VDRL, D-dimer, RT-PCR, and so on and so forth. The Kannada translation would be ಕೆಳಗಿನ ಪರೀಕ್ಷೆಗಳನ್ನು ನಡೆಸಲಾಗುವುದು. And everything that is there here is again translated here. Now the lay person's role is to find out whether these terms are understood by the participant or not. Suppose an uneducated person comes there. He may not. Now RT-PCR everybody understands, but what is this VDRL? What is this? Nothing is understood. So the layperson will say, no, this informed consent is not acceptable because there is too much jargon there, too many scientific terms there. You need to revise the informed consent document. Now the informed consent is revised and clearly written there that 5 ml of blood will be collected for blood sugar level to test blood sugar levels over the last 3 months, that is HB1AC, to test for infections including HIV or AIDS, COVID-19, syphilis. Now syphilis is not known to everyone. Usually HIV and AIDS are known to the others. COVID is known, syphilis is not known. So you can further use a bracket to explain what the syphilis is. So you can write a bacterial sexually transmitted disease. If you feel that this is also a little complicated, you can further simplify it. As much as possible, you have to simplify. Now this gets translated. So HIV, AIDS, assuming people know, otherwise that also has to be translated. Now here, everything has been explained in simple terms. That bacteriada, laingikavada, haraduva roga. So it's clearly saying that it is a sexually transmitted disease caused by a bacteria. So now the person can have questions in mind. Why are you testing for all this? This can be during the part of discussion and clarification of doubts, these can be clarified. Now the lay person will say, okay, now this is understandable by a lay person. So when he or she, the lay person in the ethics committee says, yes, it is understandable, then it gets reviewed and accepted. So this is a role of ethics committee. Despite the translations, it's important to see whether everything is understood by them or not. The next question is, who should take the informed consent? So informed consent should be taken by the investigator, the principal investigator, because he or she is the person who knows everything about the research and has the sole responsibility of the research participants' rights and welfare. But in some instances, the main investigator can delegate this job to one of the research team members who is GCP trained, because that's very, very important that whoever is taking informed consent should be trained in the GCP guidelines. Now, whose consent to be taken? So are all patients in a position to give consent? So they should have the capacity to consent. That means they should have the ability to understand that there are risks, there are benefits. They should know that they need not always say yes for this research and that it is voluntary. They should understand that they can refuse, withdraw from the study. They should be in a position to make a decision. So usually most of the people will be able to do it, but there are some groups of people who will not have the capacity to consent, particularly children, mentally challenged people, or people with psychiatric illnesses, or people with dementia, old age group, where they have Alzheimer's or some form of dementia, degenerative condition. They will not be in a position to give consent because they don't have the capacity to consent. So in such cases, you cannot take their consent directly. So in case of children, you have to depend on parent or the legal guardian, or in all other persons, legally acceptable person. That is what we normally call them. So they may not be legally authorized. You don't have a paper which says that on his behalf, somebody will take the decision. It may not be written legally in a legal document, but it's usually the next of kin. So those people can, they are the ones who can give consent. So that's called surrogate consent. But in children, it's slightly different. A little older children, 12 to 18 years of age, because they have some amount of maturity to make their decisions, like should I go for medicine or should I go for engineering? They have the capacity to decide about their future. And therefore, I think they should be able to give. But legally, they cannot sign a consent form, because less than 18, they cannot sign a legal document. And therefore, a parental consent is a must. Along with that, you can also take a written consent of the child, which is called assent. So we don't call it consent because it's not from a mature person who can give consent. It's from a person who is 12 to 18 years old, and therefore it is called assent. Suppose the child refuses and the parents agree, the dissent, that is the negative assent, I don't want to participate, should be respected. So we should not go by the decision of the parents, but you have to have a yes by both of them to involve them in research. If it's a child, a younger child than that, 7 to 12 years of age, oral assent, there's no need for a written assent as per ICMR guidelines. Oral assent has to be taken, and that has to be documented. So you write there that the child who is 10 years old is able to understand to a great extent, and oral assent, the child has given oral assent, and this for documentation of this, you can sign there, you can take the parent's signature, and if possible, an independent witness signature. So it should be documented. And again, dissent should be respected. If a child is less than 7 years, there's no assent required, only parental consent is adequate. So only in children less than 7 years, only parental consent. Otherwise, you read assent of the child, whether it is oral or written, depending on the age of the child. A few more points, then I'll finish. How should the informed consent be taken? It should always be free from any kind of coercion or undue influence or fraud or misinterpretation or mistake. Nothing. Everything should be very clear, transparent, and there should be no double meaning. I'm saying this, but I'm meaning this. That should not happen. Only then we can call it a free and voluntary consent. So what words should not be included? You should not misguide them by saying, this is research, but this is the best form of treatment that is currently available. This is clearly misrepresenting the research, idea of research. So the patient will think this is the best thing for me and will go for it. So that should not happen. You cannot say, if you do not participate in the study, or if you wish to withdraw from the study in the middle of this, the follow-up, you will not be considered for the free surgical policy for the hospital. That's clearly saying that if you don't participate, indirectly you will be punished, because you will have to pay for your surgeries in the hospital. So that is not acceptable. That is not acceptable. If any complication occurs, you cannot write in the PIS that during research, if you have a complication, you cannot hold a researcher responsible for it, because that is not correct. That should not be represented like that. All the tests required for the surgery are free of cost. It's inviting them based on the feeling that everything is free of cost here. That also should not be done. If the tests are being done and the sponsor is paying for it, you can clearly write that the following tests will be done for your research, and you don't have to pay for it because somebody else is paying, the sponsor is paying for it. If the whole idea of saying free of cost is very inviting for them, and therefore that should not be done. So such PIS will clearly be rejected by the ethics committee. And the informed consent should not be taken at the last moment, because there's a lot of things for them to discuss with their family members, particularly when it is a research trial involving healthy volunteers, and you're telling them don't get pregnant for 1 year. It's very important decision where they have to go back, discuss with their family members, is that okay, and then come back with a decision. So you cannot tell it on the previous day and say tomorrow the research is going to start, today you have to tell. It's very unfair if you do that, and therefore you have to give as much time as possible, suppose sometimes even a month, for them to decide when it is very, very critical decisions for them. Usually the PIS is written in the form of, you are invited to the study, you will be given this drug, you may have these complications, you may have this. So it's all you. Whereas the informed consent says, I am willing to participate in the study. I have understood the content. I have understood the risk, I agree to participate. So all the informed consent lines are written in the starting with I, and there are contact details in the PIS, whereas in informed consent form there are signatures. So this is the difference between, otherwise it's corresponding to each and every point that is written in the PIS is referred to in the ICF. The signatures, who should sign? Both the participant and the signature. If only one has signed, that means it is not a legal document. It is not acceptable. So it's considered void if no signatures are there, or if only one party has signed. If it's an illiterate person, you have to take a left-hand thumb impression, and it should be attested by an impartial witness. Now, who this impartial witness is should not belong to the patient party, should not belong to the doctor's team, should be somebody and should clearly write there that I have witnessed this informed consent process. All the information has been given and is apparently understood by the participant in my presence. So, and then that person signs and puts the date and gives the contact details. So in case of any litigation in future, that person will come and say that, yes, I was there at the time and all the information was given or not given, whatever it is. So in all research, is a written consent always mandatory? Mostly the answer is yes. Occasionally, in some researches, it may so happen that, say it's an HIV patient and says that, I don't want to sign here because I'll be identified. I want to give only an oral consent, verbal consent. So in such cases, once again, the same can be documented there in the presence of an impartial witness. However, ethics committee has to approve such verbal consent. You cannot take verbal consent without approval, prior approval by the ethics committee. So this is very rare. It can only sometimes happen based on the nature of the study. There is also a recommendation that whenever informed consent is being taken for vulnerable people, you have to do an audio or visual recording, because there's lots of the many studies which were conducted without appropriate informed consent process, and therefore when they looked into it, signatures were there, but participant says, I was never told all this. Nobody told me about the benefits. Nobody told me about the risks that are involved. Nobody told what responsibility was there. So there's a lot of lack of clarity, and therefore for adequate documentation of the whole informed consent process, audio visual recording of the informed consent was recommended, particularly for clinical trials involving vulnerable population. But among vulnerable population, there are two groups which have been it's said that you don't have exempted from the audiovisual recording, and that is people with leprosy and people with HIV, because the audiovisual recording will identify them and they can further stigmatize them and cause discrimination. And these two groups of people are leprosy and HIV. So only for them, because they are vulnerable population, if you are including them, then you don't have to take a audio visual recording of you have to take a written informed consent, but that can be only audio recorded rather than audio visual recording. So these are the 5 components of informed consent. One is competence, that is the person should be able to give consent. You have to give all the information, which is called disclosure. Person has to understand and you have to test the comprehension. The decision should be voluntary and the agreement should be documented. So these are the 5 very important components. It's required as per Nuremberg Code, which came after the Nazi experimentation. It is also required as per the Declaration of Helsinki, wherein it says that a written consent has to be taken, in which case, if a person is not able to give consent, a legally acceptable representative should give consent. The Belmont report, which came after the Tuskegee syphilis trial, also emphasized on informed consent. The current GCP guidelines say prior informed consent. it cannot be retrospective, it cannot be later. Prior informed consent should be taken. Informed consent should be approved by the ethics committee, and legal rights of the participants are to be protected. Ample time and opportunity should be given to give for informed decision making, and there should be no coercion or undue. These are exactly the words from GCP guideline. ICMR guidelines also talk about informed consent, and they give the participant should be fully appraised of the research, and voluntary informed consent should be given. Okay, so question is it a legal requirement? Yes, it is a legal requirement. It's also a moral and ethical responsibility of the researcher. In some research, you can ask for a waiver of informed consent, particularly when you are involving research. We are doing research on anonymized blood samples. So you don't know whose blood sample it is. You don't know whose histopathological block it is. You don't know whose slides they are, or you don't know whose fundus pictures they are. Or you have data, you don't know whose data it is. Completely anonymized. It's not possible to go back to the identifiers. In such cases, the researcher can ask for waiver of consent. This is as per ICMR guidelines. So we don't have time for stories. So with that, I'm ending. And we have a small questionnaire also to find out whether everyone has understood about informed consent or not. And we'll share it with Dr. Shivanand, who can share with everybody. So with that, I conclude this presentation. I hand over to Dr. Ravi Vaswani for the next session. If you have any questions, put it up in the chat box and we can take it later. Is that okay?
Ma'am, one question is there. Okay. It was very elaborate presentation with
thank you.
Electronic consent. Some light on.
Yes. I wanted to add it in the end, but I didn't. So in this COVID time, it has been very difficult to take consent from the participants with face-to-face interaction. So it's not possible to give. In which case, there have been apps which allow us to take electronic consent, but the problem is that digital signatures are not available with everybody. How do you know? There are many ethical issues with that also. Even if you are taking an electronic consent and the person from the other side has understood everything or not, you cannot you cannot assure that the person has understood everything. You don't know who actually is pressing or giving a digital signature. How to withdraw from the study? So you have agreed for the study, halfway, how to withdraw that electronically given consent. So many issues associated with it, but with time, I think we'll all get over it, and electronic consent may become really available for many researchers. At the same time, we also have Google Forms in which there are questionnaire-based studies, and it clearly says that if you click on the submit button, it will be considered as acceptance to study. So that also is there for low-risk studies, but for high-risk studies, there are apps which are available wherein you can load the whole PIS and give it to the people. So we had a presentation in a recent research ethics conference in which we discussed about the ethical issues in electronic consent form. And there's still a lot of issues coming up with electronic consent, and hopefully we'll get over these.
And there's another question regarding how should the EC consider while analyzing the need for verbal consent in addition to benefit versus risks?
Yes. So when it comes to when it's come to a situation where the research participants are saying that we don't want to sign this consent, this usually happens, when there's a legal angle also. So we had a study wherein the participants were supposed to tell something about the drug abuse and from where they were getting the drugs, and who were the people who were giving them the information about drugs or supplying the drugs. So when such information was there, they said, we don't want to give informed consent in a written. We want to participate in the study. We want to give information, but we don't want to sign there, because once we sign there, we are afraid that we will be identified. And the ethics committee at that point of time can look at the harm that can occur by documenting this type of informed consent in a written form, and then can assess whether verbally given consent can cause any harm to the participants. If no, then the ethics committee can go ahead. So it will all depend on case-to-case basis. So if it's a very small thing like say HIV or stigma, then you can consider, is it possible for the PI to keep this really confidential? If it is possible, then you can say, no, we insist on, and it's also important for us to understand who is asking for verbal consent. Are the participants asking for verbal consent, or is the researcher wanting to take verbal consent? Because if the researcher is asking for verbal consent, then you have to think twice. Is there a real problem, or it's just to make it more convenient for the researcher that he or she is asking? So if the participants are asking, then you can think of it. So you just, it's all case to case basis that you will have to think about.
Yeah. Thank you, ma'am. Thank you for your excellent presentation.
Thank
And
you,
especially,
Shivanand.
your that successive box presentation was excellent. It's a
Okay.
very good concept where we know that it is very easy for us to understand and even remember. And that when you're finishing, we know that yes, I have gone through all these things. So that yeah, it is a very good concept. And
Thank you so much.
yeah, so thanks a lot, ma'am. So now we can go ahead with Ravi sir's presentation. If
yeah, sure.
sir,
Thank you.
yeah. So the next session is by Dr. Ravi Vaswani. Sir will be speaking regarding vulnerability in research.
No, sir. No, sir. I made a slight change in the timetable.
Okay, sir. No problem, sir. Yeah.
I'll be talking on. So now we will quickly try to finish what the Indian GCP guidelines says about responsibilities of various stakeholders in the research. So my topic is going to cover sponsor, monitor, investigator. EC members to a large extent have already covered in yesterday's session. So we will just focus on sponsor, monitor, and investigator and try to finish within 20 minutes. So the various numbers that are mentioned here are referring to the numbers in the GCP, Indian GCP guidelines, so that you can quickly go and find out from the Indian GCP guidelines. And I presume that you have all downloaded it yesterday. If you haven't, please download it from the CEDESCO website. So 3.1.1 says that it is the sponsor's responsibility to select the investigator and the institution. And that's what we've seen always. So how it happens in India in clinical trials is there is a clinician who enjoys a big reputation as a good clinician. So the pharma company, the medical representative of the company will be roaming around the city and he will hear that, okay, so-and-so is a big doctor, well, reputed. And he will communicate this to his company and the company will decide, let's identify him to be our investigator at this site. So suddenly they'll say, okay, Mangalore, so-and-so doctor is very famous. Let's ask him if he can take part in our study. So they'll make his institution an on-site for the research study. So this is how it happens. And it is also the sponsor's responsibility to make sure that the study site has all the facilities, is appropriate, is available before signing the CTA. So there should be a complete exchange of all the information from the sponsor to the principal investigator and from the principal investigator to the institution. So the agreement in this research program is going to be basically between three people: the sponsor, the institution, and the investigator. Such an agreement where there are three parties involved is called tripartite agreement. So the clinical trial agreement is usually a tripartite agreement, and it should be submitted to ethics committee as a copy, because ethics committee needs to know all the terms and conditions that are being shared between each of these people. So there is a formal contract and a legal agreement with the investigator and the institution signing it with the sponsor, and the sponsor's responsibility to enter into this contract. So supposing there's some complication later on and a flaw arises with the contract or with the CTA, the sponsor is responsible for it. The sponsor also responsible to establish detailed SOP. So in a multi-centric trial, there have to be some things common at each place. How the informed consent is going to be taken, how the participant is going to be screened for recruitment, how the participant will be recruited, what diary will be given, when it will be given, how frequently will the patient have to fill the diary. All of these things require a commonality. So at site A, if it happens this way, at site B, C, and D also should happen the same way. For this, the sponsor prepares what's called as an SOP manual for the investigators and gives it to each investigator at each site, saying you have to follow the SOP manual. So that is the responsibility of the sponsor. Allocation of duties is also the sponsor's responsibility. So what I'm doing is, what the points are highlighted in red are the key points that we need to focus on, so that I can move a little fast instead of reading all the words on the slide. The study management, the data handling, and the record keeping. These are also very important things that is a sponsor's responsibility to keep track of. The sponsor can delegate any or all of his responsibilities, and then they usually do that to what are known as CROs. A CRO full form basically is Contract Research Organization. It's not clinical research. We tend to think of clinical trial and therefore clinical research. We think CRO must be clinical research organization, but it is not clinical research organization. It's contract research organization. So very often the sponsor may be a company sitting in, say, in Sweden or in USA. They may be multinational, in which case they will have a branch in Bombay or someplace. But the trial to be conducted in Mangalore, they may want to sublet, or they want to outsource their work to a contract research organization. So they hire a local CRO. So what the company does is, it's got a base in Bombay. It wants to do trials in in each of the states. So in Karnataka, they will identify the capital, Bangalore, and they say we'll have a CRO in Bangalore. And they will pay that company, that organization, money, and they will come into an agreement with them saying that these are the responsibilities which have been given to me by the GCP guidelines, which I'm handing over to the CRO. And the CRO will do this on behalf of the sponsor. The CRO will then identify site management officers and place those site management officers in each site. So there are these site management offices on each site. So if, let's say, some company fellow contacts me and wants me to do research from their company, they will hire a CRO in Bangalore. They will have a site monitoring officer sitting in this. We have to give him a room somewhere in this place. Usually we have what is called as clinical trial unit. So he will sit there and he will monitor the clinical trial, and whether I'm doing the work according to the guidelines, according to the SOP or not, is the thing that he will see. So the word monitoring here has got dual meaning, unfortunately. In the GCP guidelines, the word monitoring refers to a person brought in from the company side, from the sponsor side. But the word monitoring in ethics in the ICMR guidelines as well as in the NDCS guidelines means the monitoring that the ethics committee does after giving approval to a research protocol. So, but here in this particular session, we want to use the word monitoring for a monitor appointed by the sponsor to look after the work at the site. It's also the sponsor's responsibility to keep secure custody of all the documents, all the materials, everything related to the research for a period of 5 years. From the completion of the study or from the submission of data to the regulatory authority, whichever is later. So if it's a clinical trial, all research related documents have to be kept for a period of 5 years. Non-clinical trials, for academic clinical trials, the documents can be kept for a period of 3 years. From the date of completion, not from the date of starting. So it's when a site gets completely closed, when after all the data collection is done, the sample size is met, the follow-up of all the patients, even the last person. So I may take 2 years from the first participant to the last participant. And if the study is going to run for 3 years, my first participant will be followed up for 3 years. But my second participant, the last participant, will also be followed for 3 years. It goes on for another 5 years. For 5 years, I'll keep the site open. When my last participant has completed his final follow-up after 3 years, I'll submit all my records. I'll have all the leftover investigation products to hand back to the management, to the sponsor. The sponsor will come to the site, have a look at the site, collect all the investigational products, collect all the logbooks, the case record forms, everything that needs to be collected, because he has to keep it under his custody. And he will declare the site closed. When this letter comes to the ethics committee, that is the date we consider the date of closure. From that date, 5 years, it has to remain in safe custody of the sponsor. At the end of 5 years, he's supposed to destroy it. Nowadays, it has become a very unhappy trend in sponsors, because what they do is they indefinitely keep the data with themselves. They don't delete it. They don't remove it. So they write 15 years, 20 years, we're going to store the data and we're going to reuse it. We're going to we're going to sell it to different other companies. So we try to obstruct this. We try to say this is not correct because this is Indian people's blood samples, urine samples, public data, I mean, private information and data about the person. He is giving you consent for this one particular research. He's not giving you consent for 20 researches in future. And therefore, we wanted to come back and take consent from these people every time. So please inform your participant in the first research that I'm going to be storing your sample for this many years. I'm going to share it with anybody and everybody. I might even sell it to them. They might do different researches. Are you okay with this? And only if the participants are okay with it, can they sign the informed consent? So they should know that this is what's going to happen to their data. Unfortunately, most of the companies don't write this in the participant information sheet. They just vaguely write that we are going to store your samples and then share it. So we ask them to write it very specifically. They don't like us, but sometimes we put our foot down and we insist, especially when the risk is high. Sometimes we may overlook it if the risk is very low. Payment of compensation. 3.1.6 says it is the sponsor's responsibility to pay compensation for participation. It's not compensation for a serious adverse event. Here again, we have a slight problem with the terminologies. So compensation, everyone thinks of compensation as some harm that is done, and some harm, when you replace that harm, you call it compensation. Compensation also here means reimbursement. So in the good clinical practice guidelines, when they say compensation, they mean two things. One possibility could be reimbursement. So if the participant got a bus, came to the site, spent 50 rupees on the bus, stopped at some roadside dhaba, ate 50 rupees worth of lunch. So stuff like that, all that gets counted as compensation for participation. It's not compensation for serious adverse event. So that's a difference. Okay. The sponsor will also confirm that without the EC review, the study will not happen. And the sponsor has to pay the sitting fees to the EC. And each EC has got its own rates fixed up, and we have our rate put up on this website. You can have a look at it. Depending on what type of clinical trial it is, we have different categories of payments. So sponsor also needs to submit what is called as an investigator brochure to each site. Each site will have one single fact book called the investigator brochure, which details all the information about that investigational new product. What is the chemical nature of that compound? What is the physical property of the compound? What is the interaction of this drug with other drugs? What are the animal study results? What are the preclinical trial results? What is the phase 1? If there's a phase 0, all these reports come up in the investigator brochure. What are the side effects? What are the adverse events of possible adverse events of this drug? Everything comes inside. What is the dosing? How should be given? What is the route of administration? All of that. It is the investigator's responsibility, which we'll come to later, is to read the investigator brochure very well, and you should know it thoroughly, because the investigator brochure is the A to Z about the investigational product. And we tell our PG students that even in clinical research, in clinical healthcare, they have no business writing a drug to a patient if they don't know the side effects of the drug. So they should not only know the good effects, but they also know the side effects, and then only they should be able to use that drug. Because every drug has got good effects and side effects. Every drug is like a double-edged sword that cuts both ways, and they should know everything about the drug before they can prescribe it. So many of our PG students are not aware that azithromycin can prolong the QT interval in the ECG and can cause death. So they write azithromycin for a 1-day history of fever for a patient who's got viral fever. He must be an elderly gentleman, 65-year-old, already had a heart attack, QT interval is long. Azithromycin he takes, and the QT interval becomes longer, he dies. He died exactly because of azithromycin killing him, but nobody realizes this. So we have to be knowing each the effects and the side effects, and in the case of research, all of that information is given in the investigator brochure. How the supply of the IP's investigational product will be done, how it should be stored at the site, who should handle it, how should we handle, what should be the storage at which it should be kept, how much, some of the drugs required to be kept at 4 degrees centigrade, some required to be kept in a cool place but not inside the fridge, some required to be kept at 0 degrees centigrade, some required to be thawed, not thawed. There are various things that are required. All of that comes in a logbook, which the sponsor submits to each site, and somebody in the site is responsible to maintain all of that in logbook. So he'll say, check the temperature of the refrigerator at found to be correct at 4 degrees Celsius on so-and-so date, so-and-so time. Next check, so-and-so date, so-and-so time. And they'd write that. And we in the ethics committee, when we go for site monitoring visits, we have a look at this. Because if somebody is missed out on taking care of the investigation product, if they allow the fridge to become warm, that investigation product might get denaturized with the protein and it will not have any effect. It can cause harm and risk to the participant. So that gets included as a part of the sponsor's responsibility to make sure that supply is done properly, the manufacturing is done according to what is called as good manufacturing practices. Just as we have GCP guidelines, the laboratory people have what is called as GLP guidelines. They have good laboratory practice guidelines. And the pharma company people have got good manufacturing practice guidelines, GMP. So they have to produce according to GMP. They have to hire only that lab which is GLP accredited, and they have to go to that institution where the researchers are GCP accredited. So that's how it works: GMP, GLP, GCP. Okay. Further, it is also important for the sponsor to evaluate the ongoing safety evaluations. Sometimes the drug may change its risk factors. So, like we had a study on sotagliflozin which got completed 3-4 years back, but in the middle of the study, we got reports from different other sites that it also causes gangrene of the scrotum. So this is an anti-diabetic drug, sotagliflozin, especially useful in patients who have heart failure. And suddenly now reports are coming in that it can cause gangrene of the scrotum, which was not reported when we gave the approval to the study. Now, it's a serious condition. If somebody gets gangrene of the scrotum, it's going to be very painful and very effective, and the patient will lose his testicles. So we had to go back to the PI saying, we got this information from the other sites, so you have to now change your informed consent. So by the time company already sent the informed consent form, a revised version. And then we told them that you have to follow the revised version. When we come for a site monitoring visit, don't show us the old informed consent, show the new informed consent starting from this date. But all those participants in the back who already had the informed consent done, please call them back again and take reconsent using the fresh form, because there is a different risk now. So if the participant is told that there's a new risk, if he wants to withdraw, he should be given a chance to withdraw. If he wants to continue, he may continue. 3.1.11 in the GCP talks about the responsibility of the sponsors with respect to adverse drug reaction reporting. So the sponsors to provide ADR and AE forms to the investigator to the site. There's a slight difference between ADR and AE. An adverse drug reaction is an adverse event that is quite likely associated with the drug because another drug in that family is known to produce a side effect. An adverse event, on the other hand, has a lesser degree of certainty of connection between the causal relationship between the drug and the side effect. So there's a slight difference between ADR and AE. Okay. Also, the study reports have to be made sure that the sponsor does all that. Sponsor needs to monitor. So monitoring of the site by the sponsor is done through the monitor. They also need to conduct audit. The auditors, when they select the auditor should be independent. Auditors should have documented evidence of their observations. And if the auditor feels that the site is dangerous to participants and too risky because they're not following our instructions, they can recommend to the sponsor to terminate that site in the study, and the sponsor has the right to do that as per the clinical trial agreement. Okay, there can be a coordinating committee. There are multiple sites set up because different sites have different stages of progression. One site will be recruited, one site will be selected and identified early, and they already have started the recruitment and collected 30 patients. Another site will be still in the process of getting ethics committee approved. That there are different sites at different stages of progress in the research protocol work. So the coordinating committee will sit and look at all of these things. Okay, it's also the sponsor's responsibility, if in the case of premature termination or suspension, to notify the investigator, the institution, the ethics committees, and the regulatory authorities if the sponsor decides to prematurely terminate or suspend a particular site. Okay, this is what I told you about the CRO, the Contract Research Organization. Okay, now we come to monitor. So 3.1 is all about the sponsor and his responsibility. 3.2 is about monitor. The monitor is the principal communication link between the sponsor and the investigator and appointed by the sponsor. You should have adequate medical, or nowadays actually what they do is they find more common to use dental. There are lots of dental graduates who have no jobs. They go to Bombay, they go to Bangalore, they go to big cities, and they take quick training in clinical research. They do a PhD diploma in clinical research or a master's in clinical research, and become hired by CROs to act as monitors. So the responsible monitor to oversee the progress of the study, to ensure that the PI is maintaining the standards of the protocol, the GCP, as well as the SOPs that the sponsor has provided. Monitor should also confirm that investigators should always be available at the site and not simply handing over the responsibility to somebody else. You should ensure that the institutional facilities are adequate and will remain adequate. Sometimes they'll say film is not available, or the lab says that if we run out of the reagent, we don't have some. That should not happen. That's the monitor's job to make sure that these things happen on time. The monitor verifies the IP stock, the investigation product, how much of it is lying in the fridge, how much balance is remaining, when is the next supply due. All of these things are looked after by the monitor. Okay. So this is much of the responsibility of this part of the monitor is given to the PI, to the investigator, but the monitor needs to supervise what the PI is doing with respect to the necessary instruction or proper handling of the drugs, how to maintain the record, what diary, what entry should be made by the patient in the diary. Make sure that the investigator has received the latest investigator brochure edition and all of these things. So the monitor also needs to verify that none of the parties delegate any assigned functions to any unauthorized individuals. So if the PI job to do that, it should be the PI job to do. So that's why we have in this committee what's called as a delegation log. The delegation log basically says each research team member gets a code A, B, C, D, E, F based on the order in which they submitted it to us. In every column of A, B, C, D, and E, there are different tasks assigned in the first column, starting from conceptualization of the design all the way up to publication. There are about 30 odd steps. Who is going to be responsible for which of these steps? They have a tick mark, right? So they may say A, B, and C are responsible for conceptualizing the design. C, D, and H are responsible for informed consent process. A, I, and K, and so on and so on. For every particular activity, who are the people who are going to do it should be ticked to that. And the delegation log, the monitor keeps on his wall in his room, and every day looks at it and decides, okay, today I'll go and check on so-and-so person. I'll go and check on the junior research assistant. What are his responsibilities? A, B, C, D are responsibilities. Okay, let me go and see whether he's doing them according to the SOP or not. And that's how he monitors the site based on the delegation log. The monitor will frequently report to the sponsor about the subject recruitment rate. And if he's not happy, he can communicate to the sponsors who are not happy with it. So he may, for example, very slow recruitment. 6 months have passed after ethics committee can approve, not one participant has been selected. Or ethics committee gave approval yesterday and today all sample size met, 100 patients recruited in the part. So these are things that too fast or too slow rates of recruitment. The monitor can write a red alert mail to the sponsor. Ethics committee also takes cognizance of such slow and fast recruitment rates. So if there's any PI who reports to us that he collected samples in a day or two within like 100 participants is recruited in 1 day or 2 days, or 2 years have gone over and not even one participant is recruited, then we find either very slow or very fast recruitment to be a challenge, and we conduct what is called as for cause site monitoring visit. So site monitoring visit has got certain indications when we can do a site monitoring visit. So those indicated things are called for cause site monitoring. Otherwise, it's just routine site monitoring. So there are two categories of site monitoring visits: for cause and routine. In the site monitoring visit, we go and look at every single thing that is there, all the data, all the documents, check the informed consent forms. Is it signed by the participant? Is it signed by the PI? Is it in the language that the PI and the participant understands? Is it the correct version? Everything. We look at the fridge, we open the fridge, we ask them to show us the data, we ask them to open their computers. If it's password protected, we say unopen the password. If they say it's confidential, we say the law allows ethics committees to access every single data of yours. You cannot obstruct us. We will report to the DCGI if you're blocking us. And then they open up all the documents and they show us. We have a look at everything. So it takes we have 4 members in our site monitoring visit team, and it takes us nearly about 4 hours. Each of us looking at different aspects of the site monitoring visit. So it is also the responsibility of the monitor to make sure that the case record forms, the CRF, the case record forms are correctly filled out and up to date. So we have a tendency to see a patient today, write the case sheet after 2 days. That's not allowed in research. The monitor will make sure that on the day of the recruitment, whatever the findings are there, those findings should be written on the case record form that day itself. Nowadays, they have electronic case record forms, so you can't manipulate. Everything has to be filled in on that day and it gets time stamped. So you can't write today with yesterday's backdating. So that's a good benefit of eCRFs. Okay. So now come to investigator. The last part of the investigator responsibilities. The investigator should be qualified, which is as per the ICMR and the NDCGR guidelines, and he should understand the time and other resource demands that the study has to make on him. Very often, busy clinicians who don't even have time for academic work land up taking clinical trials 1, 2, 3, 4. So we know that they are not going to be able to dedicate enough time for the clinical trial, but because the method by which companies employ investigators is based on the reputation, on the clinical reputation of the person. That's how the system works in India. It's sometimes a problem. Now, in the middle, the DCGI, some NGOs went and public interest litigation, and there was a judgment passed saying that no investigator can be undertaking more than 3 clinical trials at a given point of time. So beyond that, he's not allowed to take part in, and he's not allowed to conduct a clinical trial. So the industry went and complained to the DCGI saying this is a very strict rule. After all, you're our friend, we are your friend, we'll do whatever we want to do. Please change this. So the DCGI said, okay, it's not the government's responsibility to ensure that whether the clinician has got more than 3 trials or not, it is EC responsibility. So now it is the EC responsibility to decide. There's no fixed number 3, 4, or 5 anymore. The clinical trials, any number of clinical trials can be taken by one single PI at any point of time, as long as the EC feels that he or she, that the principal investigator, has ample time to pay attention and give some attention to that study, which is very unfair, because putting such responsibility on the ethics committee, which is not taken seriously in most institutions, is a very sad thing. So the ethics committee is like a tiger. What is that? Tiger without teeth, a paper tiger. So it was better off with the DCGI. The DCGI would tell them, no, you can't do this, and they would not do it. Anyway, that's how it is right now. So the time understanding that the PI should, it's the responsibility to understand the time, is given in the GCP guideline 3.3. So they cannot say there's no such rule. There is an indirect rule which the GCP doesn't directly say you can't do this many trials or not, but it says understand that the time you are going to be contributing to the research is satisfactory or not. The investigator should be aware of and should comply with the GCP SOPs and applicable regulations from time to time. So when a sponsor approaches a clinician, they first thing ask him, are you GCP trained? If you're not GCP trained, they take it upon themselves to fly him to the nearest place where he can get his training and then fly him back so he can start the study, because he gets a GCP training certificate. The GCP training certificate has a validity of 3 years, after which he needs to get retrained. Same thing for ethics committee members. Ethics committee members also need to have GCP training, and that's valid for 3 years. The investigator is responsible to take care of the medical care of the subjects or the participants. Also, if they want to withdraw, they should be withdrawn. Not just giving them care till the end of the study, but sometimes even beyond, for a reasonable period of time beyond. Some drugs may have long-term effects. There may be some anti-cancer drugs, some chemotherapeutic agents that might have long-term side effects for a period of 6 months to 1 year. So if the ethics committee says you can't stop the study at this point, you have to continue for this many years beyond the closure of the data collection, and then they have to continue with that. So this is the responsibility of the investigator to continue giving care till such time that either the sponsor or the ethics committee feels that now it's a reasonable time to close the study. Okay. Communication with the EC is the responsibility of the PI. And this is the point I was trying to raise yesterday. 3.3.4 in the GCP says it is the PI's responsibility for all communications with the ethics committee. And the ethics committee will only communicate back with the PI and not with the sponsor. Okay. You have to properly report deviations. You have to promptly report risk change if there any change in the risk to the subject. You have to promptly report all adverse drug reactions and adverse events. Any new information that may adversely affect safety of the subjects. And for deaths, there is additional information in terms of autopsy reports and terminal medical reports have to be submitted. So all of these have to be very important communications from the point of view of the investigator. And most often the sponsor does it on behalf of the investigator. The investigator simply sign a document and enjoy the benefits of the research, but the sponsor does all the hard work for him. So he promises to comply with the protocol. That's a part of the clinical trial agreement. It is the primary investigator's responsibility to do the selection of all the study subjects. Keep records and reports. Okay. That's it. That's about the rest of our ethics committee members. We have already finished that yesterday, so we know what are the roles, responsibilities of the various ethics committee members. Thank you very much for your kind, patient hearing. The next session will be vulnerability by Dr. Uma Kulkarni.
Yeah, thank you, sir. It was indeed an excellent presentation. I know that you had to.
I'm sorry, sir, I can't hear you. Can you please unmute yourself?
Sir, I have unmuted myself, sir. Now you can hear me, sir?
Yes, yes.
Yeah. Sir, it was an excellent presentation. So thank you very much. And I sincerely thank both of you that even though ma'am is not there, you have managed to cover her up and do her part. So I know it's very difficult to speak for prolonged duration. So thank you very much, sir.
Thank you, sir.
So yeah. Now I request Dr. Uma Kulkarni ma'am to kindly continue with her presentation on vulnerability in research.
Yeah. Thank you so much.
Yeah.
Okay. Sorry.
So, when a research protocol comes to our ethics committee, the first thing we see is, are vulnerable populations involved in this? So is it on students or is it on psychiatry patients? Because that will help us in clearly putting the protocol either for a full review or expedited review. So vulnerability is one major concern for the ethics committee when they are involved in research. So we'll try to understand what is vulnerability based on our past experience. So the whole concept of vulnerability was there, but it was identified much more clearly after this Tuskegee syphilis trial. And we all know that in this trial, which was from 1932 to 1972, for almost 40 years, this trial was conducted only to look at the natural course of syphilis. So they just identified people with syphilis in a place called Alabama, where they were African Americans, and most of these people were very poor, uneducated people. They involved them in this study without any informed consent, and they just started observing them. And they just told them, "You have bad blood, we will observe you." And they were given some local treatment which is not effective against syphilis. And the purpose of the study was to mainly see whether how the primary syphilis becomes secondary syphilis becomes neurosyphilis or cardiovascular syphilis, and how it differs in the African Americans from the whites. So this was their hidden objective. And if we go back in history and now try to apply the ethical principles, we feel how very unethical this study was, because the participants were not told at all that it was a part of research and they were being observed. This was still okay until 1940s, but in 1947, when penicillin became available, this was considered as a gold standard treatment for syphilis, because it just cured syphilis. The whole world was receiving penicillin for syphilis treatment. These 399 people who were being observed as a part of this Tuskegee syphilis trial were denied this penicillin. They said, no syphilis for these people who will continue the research. We will not tell them that this penicillin is available and it is effective. We'll just observe them and we'll complete the study, because the study is funded by US. US is going to continue the funding for this study. Today, we think that this was so unethical to do that. When the standard of care is available for participants, you are not giving them, you are denying them. That means you are not considering them as human beings at all. You are disrespecting them, not only their autonomy, but you are causing them harm. You are not giving them the benefit, and you are being unjust to them. And therefore, all the basic fundamental ethical principles are violated in this. So that's when these people were identified as vulnerable people. Why did the US funded research project, why did they not conduct a similar study on the whites? It was not possible for them to conduct this study on the whites, because they would say, how can you deny us from treatment with penicillin? Why are you conducting on, they might ask questions, why are you conducting the study on us? And whereas these people were slightly backward socioeconomically, they were illiterate, and they were easy targets for considering this kind of a study where there's only observation, no treatment until they die. And therefore, these are considered as vulnerable people in research who are likely to be exploited. And what was the effect of this? All these patients did not get any treatment. Okay, many of them died of syphilis. The syphilis, because it's a sexually transmitted disease, it was transmitted to the infected to the partners, and many children were born with syphilis, congenital syphilis. And congenital syphilis, as we know, has many deformities in the baby, give rise to many deformities in the baby, and therefore this was not an acceptable study. From this study, we learn a lot about vulnerability, and we need to understand what is this concept of vulnerability, identify different kinds of vulnerability, and identify also what needs to be done to protect them from any kind of a harm. So to define vulnerability, if you know this Achilles tendon, this was his weak point. So any injury in this would take away his life. That was his weak point. That was a vulnerable point. So susceptibility of any person or a group of people or society or even a system to physical or emotional attack or harm is considered as vulnerability. If you ask me, in research, every single participant, even if it is a person like me, will be vulnerable. I am educated. I don't belong to the lower socioeconomic group. I am not an ill person. I'm not unconscious. I'm not a child. I'm not a pregnant woman, but still I would be considered vulnerable because of the risk of harm inherent to research. But here we are talking about those groups who are more vulnerable, who are more susceptible to harm than the other populations. The harm may not be always the physical harm. It can be social harm. It can be psychological harm, or any form of harm, including dignity, the harm to dignity. So who are the vulnerable groups when it comes to research? Children, because they are immature, they will not be able to take their own decisions, and somebody else is taking decisions for them. Prisoners of war, because they have lost their main rights, they can be exploited. There are many studies in which prisoners of war, not only of war, even the other prisoners are being considered for research. One of them being the Nazi experiments. Pregnant women and fetuses are again at a risk, at a higher risk than general population, and therefore they are considered vulnerable. Persons who are mentally disabled or otherwise cognitively impaired, including those who have psychological problems like schizophrenia or manic depressive psychosis, where their mood changes are different. They are at different points of time, they have a different capacity to consent. So these are also vulnerable people. Economically and so educationally disadvantaged people, we consider them as vulnerable, even if they are not mentally unsound or they are not children, because they can be exploited. Like the example we took about reimbursement, if you have to pay 600 rupees, instead of that, if you're paying 6,000 rupees, that person will be attracted to the money that he or she is receiving and might want to be a part of the research, even though the research is a high risk study. So there's a possibility that the researchers would go around saying that I will give you 6,000, please be a part of the research. And therefore, many people will get enrolled in the research without truly understanding and being ready for the risk. And they also take part in multiple clinical trials simultaneously. So that's the reason they are considered again vulnerable. Schools for the retarded, where you may just go and take permission from the warden of the schools, and all the children may become part of the research. Developing nations, if you consider, are a group is the whole group. Like for example, India. Many researches funded by the US and the West are conducted in India. India is a good hub for clinical trials because it's very convenient to conduct research here. If you give reimbursement, many people are willing to take part in research because they are now happy with that day's wages. They say, okay, definitely we are going to get so much money, and therefore many people in the slum areas of Bangalore, Hyderabad, Ahmedabad, these are places, Mumbai, these are places where clinical trials are going on so easily because people come forward to be part of the research because it ensures them that day's wages. So this is very, very important for us to understand. Also the tribal populations. So in Mangalore, we have a tribe which is often considered for multiple researches. Close to Dharwad, there is a tribe where those people have been part of so many researches conducted by medical colleges all around that place. So they are constantly communicated by these researchers to take part in one or the other study because they have a different culture, they have a different genetic constitution, and therefore everyone, and it's also easy to conduct research on them. It's very convenient to get the sample size, and people do it for purpose of conducting their research rather than because the tribal population wants a kind of research. So the issues are of concern whenever the vulnerable population is involved in study is how to minimize the risk. For example, if you're including a pregnant woman in the research, is it possible to minimize risk? If not, it is better to exclude the pregnant women from the research. If there's a research involves some condition that affects the pregnant women only, in which case you cannot conduct the study on non-pregnant women, you have to include pregnant women. In such cases, the PI has to clearly define what can be done to minimize the harm. For example, multiple follow-ups, multiple ultrasounds that are required, or repeated blood tests may be required, and good follow-up may be required, good ICU care or PICU care, maybe NICU care may be required. All these things should be first put in place, and then only the study can be allowed to be done. There should be a justice and fair selection of participants. So as we said, funded studies from the West are conducted in India. So ethics committee's role becomes very important to find out what is the sample size globally, and what is the sample size in India. If the sample size in India is constituting most of the global, then you need to ask a question: why are they conducting the study mainly in India? Is it because they want to exploit the Indian population and conduct the study because it's very cheap over here? And at the same time, after the study, are they going to be to give access to the drug at a low cost so that the people from India are able to afford this? So there has to be justice, because if the study is conducted on Indian population and benefits are not available to them at lesser cost, that means you are being unjust. The burden is on the population on whom the research is being conducted, but finally, when the drug is proven to be effective, it is marketed at a very high cost, and only the rich people, rich countries will be able to get access to it. That means you have been unfair. Burdens are somewhere and benefits are somewhere else. So that needs to be addressed. Next is safeguards and protections which are provided. So are you adequately making sure that there is good infrastructure which is available? Are you strengthening your informed consent so that the vulnerable population which is involved in the research is definitely understanding the risk and then being part of the research or not? If there is a if there's a consent process which is happening on vulnerable population, are you making sure that you are doing the informed consent adequately well? Are you audio visually recording so that there's a definite documentation to make sure that the person has understood, to make sure that there is no exploitation? This is very, very important. So these are the issues of concern which the ethics committee has to look into. When involving the vulnerable population into research, like for example, pregnant women or children in research, one question often comes: should we completely exclude them from the study? So is it possible that studies be conducted only on the non-vulnerable population, and once it is proven to be effective, then you try it on them? Is it possible to do that or not? So it all depends on how you are going to justify their inclusion and as well as exclusion. So it's not always good to exclude the people from the studies, because you want to know, suppose if you're talking about COVID vaccine, you can't just conduct studies on adults, non-pregnant women only, because you need to protect the pregnant women and children also from COVID. You want to give them also vaccine and safely. And that is why inclusion of the vulnerable population into research is also important. At the same time, whenever risk is high, they should be excluded. So that's very, very important. It's always important to look for whether there is any kind of exploitation of the participants, because you need to maintain the ethical standards, keeping in mind the principles of ethics of autonomy, beneficence, non-maleficence, and justice all the time. Minimize the harm to as low a level as possible. Reduce the harm of magnitude as well as the severity of harm, and make sure that appropriate informed consent is taken. So this is very, very important. So this is the study which we were talking about. There's a very beautiful movie demonstrating the all the ethical issues that have that are seen in the Tuskegee syphilis trial, and that movie is called Miss Lover's Boys. I'm sure Dr. Shivanand will remember watching this movie as a part of I Swear. It's available free on YouTube. I think everyone should watch this movie. The next is about children. Children are not able to take decision on their own. At the same time, adult doses may not suit them because they are physically immature. The liver may be immature, the kidneys may be immature. There's a possibility that there's a harm to a part of the body, and therefore they are more susceptible to harm. In which case, it's very important to make sure that their inclusion in the study is justified, and a legally authorized person, that is usually the parents, are taking the consent. And it should also be important. It's also important to know that there is no exploitation of children that is happening during this, while including them in study. And we also spoke about the various types of consent in the informed consent session. So I'll not repeat oral consent and written consent. So Nazi experimentation is one of the studies which was conducted on prisoners of war after the Second World War without any consent, without any opportunity for them to say no. So very serious and very brutal experiments were conducted on them, mainly on Jewish people and Jewish children, and in the concentration camps following the Second World War. So there was a lot of coercion. They were forced to take part in the study. Nobody asked them whether they wanted to be a part of it or not. And these experiments resulted in death, disfigurement, and disability of the people, which was very, very sad part of research. There's another study called the Willowbrook study, which was conducted on cognitively impaired children, actually. So there was one place called Willowbrook, which was home for the mentally challenged, retarded children. So what they wanted to conduct a study on hepatitis, and they said that there was a long queue for this of parents wanting their child to be admitted to this place where they would take care of their mentally retarded children. So they wanted their child to get an admission to the school. So at that time, what did the researchers do? They said, if you are willing to let us conduct a research on your child who's mentally challenged on hepatitis vaccine, then in that case, we will give you direct admission. You don't have to go for a waiting period. Many parents just came forward without understanding the risk. They just wanted their child to be admitted to Willowbrook, and therefore they agreed for this kind of research. So there can be a kind of exploitation and unjustified involvement of these children. Why? Because hepatitis does not necessarily involve only mentally challenged children. It involves everybody. Then why should the research be conducted on them? So that was the ethical issue there. So about that, we spoke about pregnant women and need for in detail just now, like repeated follow-ups, repeated ultrasounds, repeated blood tests to make sure that the harm is minimized. Involve the pregnant women only when it is really essential to be involved. And once it is considered safe on the others, then it can be tried out on the pregnant women. Sometimes even students or employees of the institution can be considered as vulnerable, because I would want to conduct a study where I'll tell my students, please be part of the study. And my students will think that if I say no, Uma madam is going to fail me in the exam. So they are scared. There's a hidden coercion there. There's a perceived coercion there, and therefore they will say yes to the study, whatever kind of a study I will do. So there's a kind of coercion which is understood, which is perceived by them, and therefore any employees or students or even those people in the army or wherever there's a hierarchical nature, so there's a possibility of exploitation, and therefore this also needs to be considered. So in our ethics committee, we asked for a checklist. Whenever vulnerable population is involved, we ask them, give us a checklist to say what are the safeguards that you have, what is the harm that is possible, and how you are trying to minimize the harm. What is the justification for considering these people for your research? And only when they give that and sign that document, we consider them as acceptable. So that's one robust way of making sure that safeguards are there. So that's about vulnerability. I hand over to Ravi sir for the next session on serious adverse events. And sorry for that constant change from one computer to the other computer. This is mainly to give us voice rest. Thank you so much. If you have any questions, put it up in the chat box.
Thank you, ma'am. It was a very informative and a wonderful talk by you. So I hereby request the delegates, if they have any queries to the resource person. You can put them here in the chat box. So now hereby request our next resource person, Dr. Ravi Vaswani, to kindly speak on a serious adverse event reporting. Over to you, sir.
Thank you, sir.
Yeah.
So we come to a very important part in the handling of research ethics. That is, what is serious adverse event? What are its timelines for reporting? Who will report it, and how? And what is compensation? So, an SAE is defined as any adverse event that is serious when the research outcome for the participant is either A, death, or B, life-threatening injury requiring hospitalization, or C, if it's an OPD type of research, then if it's an IPD type of research, then prolongation of hospitalization, D, significant disability or incapacity, E, congenital anomaly, or F, requirement of intervention to prevent permanent impairment or damage. So in the event of any of these things happening, it can be defined as serious adverse event. I'll repeat: death, life-threatening injury which requires hospitalization. So you have OPD people, research being done on OPD patients who are coming for follow-up from their homes, but suddenly one of them requires admission because he's got a life-threatening situation. Or if already you're doing research on hospitalized patient, you plan to discharge in 5 days, but because of the drug, the discharge became 30 days. So prolongation of hospitalization. If the drug leads to significant disability or incapacity, or if it leads to congenital anomaly, or requirement of intervention to prevent permanent damage, then these are the situations where we consider serious adverse event. So to say serious adverse event, before we say serious adverse event, we also need to first define whether was this research related harm or not. The first point to understand is the harm that is occurring to the participant related to the research, or has it happened independent of the research? Harm or loss that occurs, this is the definition of the GCP. Harm or loss that occurs to an individual as a result of participating in research, irrespective of the manner in which it has occurred. And includes both expected and unexpected adverse events and serious adverse events related to the intervention whenever they occur, as well as any medical injury caused due to procedures. So it's a very broad definition because it's broadened over a period of time, because initially it was considered as only something which is causally related to the drug that is causing the harm. But many times the companies were trying to avoid paying compensation by saying that this is not caused by a drug, this is caused by the disease condition or by some of the procedures not related to the drug. So the definition has been modified and broadened to include procedures, any injuries that occur as a part of any interventions, and it has gone on to increase not just related to the drug directly. So whenever there's a direct adverse event of the investigational product, it's obviously a research-related injury. But research-related injury also occurs when there has been a violation of the approved protocol or scientific misconduct or negligence. So let's say the approved protocol says that you're going to use paracetamol 600 milligrams, but the PI ended up giving 600 milligram 2 tablets, 1,200 milligrams. That's a violation of the protocol, and there can be an adverse effect. Failure of the investigational product to provide intended therapeutic effect where the required standard care or rescue medication, though available, was not provided to the subject as per the clinical trial protocol. So this again becomes basically a deviation from the clinical trial protocol. Now, you had promised that you will give a standard of care, but you did not. And in the absence of such standard of care, the investigational product failed to produce a therapeutic effect. Not providing the required standard of care in placebo-controlled trials. So whenever a protocol comes up with placebos in it, ethics committees have a red flag that goes up. we look at very carefully. We generally don't allow placebo-controlled trials unless there's very strong justification for it to be used. And wherever the placebo-controlled trials are being used, we insist and make sure that the placebo receiving group also gets standard of care. You cannot deny standard of care, just as Manan told you just now about the Tuskegee syphilis trial. You cannot deny them penicillin. In 1947, penicillin was discovered. It was found to be very effective against syphilis in 1948. But till 1972, these participants in the Tuskegee syphilis trial were denied a sure shot cure for their syphilis. So that is a problem. Not only that, it also creates an adverse event in the sense that the syphilitic woman who became pregnant gave birth to a congenital syphilis child. There was about some 40-50 children in that study who were born and died of congenital syphilis. So that also becomes, if the standard of care is not provided in a placebo-controlled trial, it's a research-related injury. If the adverse effects due to concomitant medications in excluding standard of care necessary as part of the approved protocol. So it need not be the actual investigational protocol, but even the concomitant medications which can cause research-related injury. Any adverse effect on child in utero because of participation of the parent in the study. Any clinical trial procedures involved in the study leading to serious adverse event. So these are all what are known as research-related injuries. Because why is this important? Because when the matter comes up to ethics committee has three things to decide. A, was the harm related to the research? B, does this participant who has been harmed deserve compensation? And C, what should be the quantum of compensation? We'll discuss that a little bit more in detail. Okay, so similar things are reported in the ICMR document. And the ICMR also says that the EC is responsible for reviewing the relativeness of the SAE to the research as reported by the researcher and determining the quantum and type of assistance to be provided to the participants. Very clear, ICMR is very clear about this. It's the EC's responsibility to do that. But there are new guidelines from the DCGI, and we'll be looking at those in a few minutes. Okay, so there are several things here. For clinical trials under the purview of status quo, the timeline and procedures as notified from time to time may be followed, and the ICMR guidelines don't apply. All research participants who suffer harm, whether related or not, should be offered appropriate medical care, psychosocial support, referrals, clinical facilities, etc. So the GCP guidelines are very clear. Whether it is harm related to the drug or not, the moment some problem happens, first thing you should do is admit this participant and treat him. The sponsor and the investigator responsibility to treat him free. Then they are given 14 days to decide whether this drug was the cause for the harm or it was independent of the drug. If it is independent of the drug, the sponsor is absolved of responsibility and need not treat the patient any further beyond 14 days. But most of the side effects get treated and managed within 14 days, and therefore it's a very reasonable rule. So irrespective of whether the harm is caused by the drug or not, the moment the harm occurs, first admit the patient, treat him. All that is done free by the sponsor and the investigator. And if there's no sponsor, then it is the institution that takes up the responsibility of the sponsor. Medical management should be free. Compensation should be given to any participant in the injuries research related. And this is applicable to both harms. Previously what used to happen is if the patient gets a side effect or a harm, he's admitted, the treatment is started, but immediately the company, the sponsor, unblinds that person and finds out whether he received the placebo or whether he received the intervention product. And the moment they say he received placebo, they take away their management of the patient, saying we are not responsible because we gave him placebo and we're not going to cover up for any more of his financial support. So the GCP guidelines are very clear about this. They've stopped this. This is one of the points where we have modified it from the international GCP. And it says, irrespective of whether the patient was in the control arm or in the standard of care arm with placebo, without placebo, all of these people should receive free medical management. Compensation may not be given depending upon whether the injury is related to the drug or not, but management of the medical care of that particular condition should be done for all participants. When deliberating on the quantum of compensation awarded to participants who suffered research-related injury, EC should consider aspects including type of research, extent of injury, loss of wages, etc. So now the new responsibility of ethics committees is to decide whether the harm is research-related, whether the harm needs compensation, and what should be the quantum of compensation, which earlier was the job of the DCGI, has now been delegated to the ethics committees. So many times we find that ethics committees are getting more and more of the work of the DCGI, who does not want to do that. Maybe the DCGI is overburdened with a lot of work. Maybe the DCGI wants to make a fine balance between going with the industry and going against the industry. So they've removed all these things and given it to ethics committee. We call this ethics committee dumping. They dumped a lot of responsibility on ethics committee, which is unfair. But ethics committees, which are doing most of the work in voluntary way, with no money benefits, doing honorary service, are getting more and more work to do. Okay. So very often we find that researchers report only SAEs but don't report AEs. But actually the ICMR guidelines 2.6.3 says all AEs also should be recorded and reported. Okay. The NDCTR rule says the ethics committee shall analyze the relevant documents pertaining to such events and forward its report to the Central Licensing Authority to comply with the provisions of the Chapter 6. And there are certain timelines which we'll be doing in a little more detail in a few seconds. Okay. It also talks about who will be receiving the compensation and what should happen with the nominations. Okay. We can skip all of these. This is again the same thing, free medical management to be provided. And all civil service events should be reported according to the timelines. I will be telling you the timelines soon. Okay, these are all the timelines in wordings. I will show a timeline in table form. So this table covers up almost everything that we need to know about the timelines in civil service event reporting. So the first column is who, the second column is what, the third column is when from the date of occurrence of the SAE. The last column is to whom. So the communication goes from whom to whom. Okay, so it's from the principal investigator within 24 hours. An initial report has to go to sponsor, to the Institute Ethics Committee chairperson, and to the DCGI within 24 hours of the harm occurring, of that serious adverse event occurring. Then, within 14 days, the sponsor or the PI has to submit what is called as a due analysis report. It should be sent to the institution head and to the DCGI. And I don't know why the guidelines have not mentioned anything about it should come to chairman of the IC also, but currently, as per the guideline, it need not come to IC chairperson. So within 14 days, the sponsor and the PI should reply to institution head and DCGI. Then within 30 days, the sponsor or the chairman of the IC has to submit analysis report and compensation report to the DCGI. So what we do is, the moment we come to know at the 24 hours point, we communicate with the sponsor, with the PI, with our institution head, and with the DCGI, telling them that we have got a report of a serious adverse event occurring, and we are waiting for the 14-day due analysis report from the sponsor/PI. So automatically the PI will send a copy to us, and this question mark gets released. But as per the guidelines, it need not be sent to us, which is actually, I find, a slightly wrong thing. It should be there. Yes. Okay. So within 30 days, the sponsor will write to the DCGI. Simultaneously, the chairperson of IC will write his own report to the DCGI. The DCGI will receive both the reports, look at them, and then he has certain options ready for himself. A, he may decide on clear-cut grounds that yes, this is compensation which is correct and should be given, and he settles the matter at that level. Or he feels it's not very clear what do we do, so maybe let's refer it to an expert committee. So then, and the guidelines don't say how many days the DCGI is responsible to send to the ethics committee, but at some point of time, the DCGI will create an expert committee and forward the documents to the expert committee. The expert committee will meet and give a recommendation on the quantum of compensation within 60 days. So whatever the chairman has given, the chairman of the IC may say compensation is to be given and quantum of compensation is this much. The expert committee has the authority to override that and give its own decision on whether the compensation is to be given or not, and what should be the quantum of compensation. This happens within 60 days from the occurrence of the SAE. And this information the expert committee will communicate to the DCGI. The DCGI will give final communication to the sponsor saying that we had an expert committee meeting and they decided that yes, the ethics committee was right in deciding that compensation should be given and that this is the amount of quantum of compensation. This should be sent to the sponsor within 90 days from the date of occurrence of the SAE. And this goes to sponsor and nobody else gets a copy, which again is very wrong. So the ethics committee needs to be brought up to date as to whether the DCGI has agreed with the ethics committee's decision, has it taken a final decision or not. But thankfully, most of the sponsors will automatically send a copy to us after receiving the data from the information from the DCGI. The sponsor has to finally make the payment within 30 days from this 90 days, not from the date of the occurrence of SAE. So only the last row is not linked to the date of occurrence of the SAE, but it's linked to the previous column, the previous row, where after the DCGI sent the letter to the sponsor, within 30 days from that letter, he has to pay the compensation and submit report on compliance with the DCGI order. Now, for those ethics committees that are going to go for NABH accreditation, There's an additional point here that is required to be noted, which is not there in the guidelines or in the rules, regulations, but they insist that lay person should be a member of the SAE subcommittee. The lay person should be present when the check is being handed over by the sponsor to the next of kin or nominee of the person who died or has received some major problems. So that's an additional requirement the NABH wants. So now we've changed our SAE subcommittee constitution to make it include a lay person as well, who comes with us on site monitoring visits also, who also looks at compensation. And so far, we have not had a situation where we had to stand in front of us and the check should be transferred in the presence of the layperson. But if it happens in future, we are ready for it. Okay. The next thing is compensation. So how is compensation calculated? Compensation in the case of death. This particular slide refers only to in case of death. The formula is B into F into R divided by 99.37, where B is the base amount, that is 8 lakhs, arbitrarily fixed. F is the factor depending on age of the trial subject as per Annexure 1 based on Workmen Compensation Act. And R is the risk factor depending on the seriousness and severity of the disease, presence of comorbidity and duration of disease of the trial subject at the time of enrollment in the clinical trial, between a scale of 0.5 to 4 as given under. So if it's a terminally ill patient not expected to live long, the risk factor is 0.5. If it's a healthy patient or expected to live long, the risk factor is 4. So it gets multiplied 4 times. Here it gets multiplied half times. And for all people in between, the factors are 1, 2, and 3. But in case of patients whose expected mortality is 90% or more within 30 days, a fixed amount of rupees 2 lakhs should be given, is what the compensation rules are saying. So based on this, we can calculate 8 lakhs into a factor which comes from the Compensation Act, which is generally works out around 1.12 or 1.2, multiplied by the risk that the patient is receiving. So if it's a patient moderate risk, it multiplied 2 times. So it becomes 10 lakhs into 20 lakhs. 20 lakhs will make payment from the sponsor to the participants next of kin in the case of death. In the case of injury, it will follow simply the Workmen Compensation Act, and all of this becomes now the responsibility of Ethics Committee. So in addition to being Ethics Committee member and reviewing protocols, Ethics Committee members have to also read Workmen's Compensation Act. That's it. Thank you very much. Any questions? I'll be happy to answer them.
Thank you very much, sir. I know it was a very tough subject. I mean, there's a lot of things involved in it and a bit confusing subject. And I think slightly there will be minor changes also. So thank you for telling us in brief all the important points. So, sir, I think there is one question from Dr. Arti Halwai. The presence of layperson during handover of check as per NABH is written somewhere.
Okay, good. Thank you. I'm sorry I had to run fast, but there was too much and there's too little time. So if you give us 5 days to conduct the GCP workshop, I'll be happy to discuss all of it in detail. Maybe even give you examples where you can work it out and make it easy. I'm sorry for that.
Yeah. Okay. Yeah. Shall we go ahead with the next session, sir?
So this is about privacy and confidentiality in research. And we all know that privacy is about how much information we want to share with somebody else. So if we were to ask, this was a PG workshop in which I asked how many of you are willing to conduct, to be part of the research where we will be checking your BP. Most of them said yes. Oral hygiene, 80%. Study of IQ, 70%. Study of habits like smoking or alcohol, 60%. I'll take 5 ml of blood and do some tests, 50%. Study of psychological illness, 40%. Study of evaluation of menstrual blood or semen analysis or similar studies. Percentage came down. For willingness came down to only 30%. Genetic susceptibility for homosexuality, 20%. Observation of sexual or other private behavior, 10%. So from this, we come to know that there are some issues which we are more than willing to share with researchers, as BP checking, or even to some extent oral hygiene or in IQ. But there are some issues which are very, very private, and many of us would not want to be part of such research. So this talks a lot about privacy, and privacy is all about a control over sharing with the others our private information, or giving information about ourselves or our behavior or anything that belongs to us. It's not just about how much, what information, it's also about how much of that information. I may want to tell some things about, somebody comes and asks me, did you have a COVID related illness? Then I may say yes or no, depending on how much I feel that it is a private issue for me. And if I am okay with it, I may not want to tell everything that about whatever I suffered during my COVID illness. I may want to tell only a part of it. So it's not just about what information, but to what extent. It's not also about what extent, it's also about to whom I will want to share my this details. If it's my treating physician, I may tell each and everything to him, but to a researcher or to any other party, I may hesitate to tell all the information. So privacy is about sharing the information in the right context, what is being shared, and to what extent it is being shared. So in research, again, privacy is something to do with autonomy, just like we were talking about informed consent. So when you take a good informed consent, it means you are respecting the autonomy of the individual. If you are taking care of the privacy issues of the patient, that means you are again respecting the autonomy of the person. Because privacy has to be ensured in research. In some research, like say obstetric research or gynecological research or research conducted by dermatology, wherein you're checking something to do with these sexually transmitted diseases and examination of the private parts, it's very important to make sure that at the time of examination, privacy is ensured. Isn't it? It's very important, just like in healthcare. But we are not just talking about that level of privacy. It's also about privacy of the data that is collected for the purpose of research, because this data is going to be disseminated. This data is going to be analyzed and used in scientific publications and presentations. So it's very important to go through all these processes, particularly the participant information sheet, because you need to tell everything about the privacy related issues in the participant information sheet, saying that we are taking this sensitive data from you. Is it okay or not? Are you willing for this study or not? So it's very important, as well as the informed consent form, in which the participant says, yes, I agree that this private information is going to be taken from me, and I still agree for the study. So that's very, very important. So in the participant information sheet, along with all the details, we also need to include whether private information is being taken for the purpose of the study. And in the informed consent, that they have understood, they are willing to give the personal information, and they have given this consent as a voluntary consent, and that there is no kind of coercion. So after collection of data, whatever we get is the information or the data. Anything pertaining to that, we call it as confidentiality. So when we are taking directly the data from the person, it's related to privacy. And once it comes to us, it becomes data. Anything to do with that relates to confidentiality. So whatever data is coming to the researcher has to make sure that its confidentiality is maintained. There may be data which is very personal, private, including addresses, including the name of the person, the community to which he belongs, the religion to which he belongs, the institution where he works. So many details may be there. It's important to make sure that it is not shared with any other person, whether in conferences or in publications. Only when there is a legal requirement, you need to disclose it. So there should not be any kind of unintentional sharing with other healthcare professionals, staff members, or even the family members of the patients. So it's very important to consider this. So we often see ourselves talking in the lift, talking about to each other about our patients. Oh, what happened to that Vimala patient? She's positive. She's positive for HIV. So the whole, all the people who are there in the lift will know that there is some Vimla who is now HIV positive. So that's not acceptable. So we need to keep this in mind to make sure that confidentiality is maintained once we have the information. So because this can lead to psychological harm, it can lead to family feuds and even legal problems. So does it mean we cannot publish anything that is come to us as research data? No, it doesn't mean that. It means that you have to delink the data completely and only publish later. So you can disseminate the data after delinking without the name, photo, religion, region, or any other identifiers. So it's very important to keep this in mind. So the more anonymous the data is, more safe it is. More the identifying details we collect, there's more chance of breach of privacy and confidentiality. So at the time of collection of data, we always look into the data collection form. How much of identifiable information is taken in this? If there's a lot of identifiable information, we try to see, is it justified to collect this information? If it is not required for the objective, please don't collect that information. If religion is not required, don't collect that the details about religion, because it's going to identify them in the presentation if it is not required for the objective of the study. So ethics committee has to make sure that steps are taken to ensure participants' privacy. And one of the questions that Dr. Praveen had asked in the informed consent session, which I saw later, was how to make sure that the confidentiality is maintained in electronic consent. It's very important. It's very difficult also. It's also difficult to know whether the participant himself or herself is giving consent or not. It can identify the equipment that from where the consent has been given, but we don't know who is the person behind it. So there are issues with that also. So we need to, as ethics committee members, we need to look into privacy and confidentiality at all the time. So we look at it in the methodology, in the PIS, in the informed consent form, and during site monitoring, how they are dealing with the details. So that's the role of the ethics committee in maintaining privacy and confidentiality. So that was a very short presentation, adequate for a 2 days workshop. Thank you so much. Over to Ravi sir for the last presentations. Thank you.
Thank you, ma'am. Thank you very much. So I know it's been a marathon for both of you. So
any questions for Dr. Uma, or shall I start?
Sir, you can start, I think, sir, because we have a small separate session for
I'll try to
question and
cover
answers
quickly in the next 10 minutes the important topic called conflict of interest. So by the end of this session, you will be able to define conflict of interest, appreciate its ubiquitous nature, know the different types of conflicts of interest, appreciate how it can influence the outcome of research, and know how to handle conflict of interest. So conflict of interest definition is, actually speaking, it should be called conflict of interests, because there are two interests, a primary and a secondary interest, but we use the term in singular. We say conflict of interest. So a conflict of interest is a set of conditions in which a professional judgment concerning a primary interest tends to be unduly influenced by a secondary interest, also known as competing interests. So the primary interest could be the patient's welfare, or the subject's no harm coming to the subject, or validity of the scientific aspects of the research. And the secondary interest would usually be a financial gain. We'll be talking about this a little bit in more detail. So a primary interest for a doctor would be a patient health and well-being. A primary interest for a researcher would be valid biomedical research. And a primary interest for a medical teacher would be education of future health professionals. So these are the primary interests of each of us, and these are the roles we all play in teaching institutions. Whereas secondary interests, which are not necessarily bad or illegal, would mean personal, such as family and friends, commercial, such as patent rights or industry influence, professional, such as fame or boosted credibility, academic, such as position of power, colleagues, funds, publications, and financial, which is money, and of course, much more than money. So we could broadly classify conflict of interest into financial and non-financial, because the way our current approach is to conflict of interest is basically to, if it's a financial conflict of interest, everyone takes it seriously. If it's a non-financial conflict of interest, people tend to look it over. So again, I'll repeat. when a secondary interest dominates or unduly influences or distorts or corrupts the integrity of a physician or a researcher's judgment in relation to his primary interests, that is called a conflict of interest. So as I said, there are two types, financial and non-financial. Non-financials are much more in number, but people tend to ignore these because wherever there are human beings, non-financial conflicts of interest are bound to happen. But it needs to be reinforced all the time. So the current standard for conflict of interest is, if it's a financial conflict of interest, it must be declared. If it's a non-financial conflict of interest, it's up to the researcher whether he wants to declare it or not. There are various levels at which conflict of interest can occur: individual, institutional, funding agency level, ethics committee, editorial board of journals, pharmaceutical companies, governments. Every institution, individual, at every level, at some point of time, may have a conflict of interest, which is why we say it's ubiquitous. At every level, somewhere there's bound to be somebody who's known to somebody, who's a relative of somebody, and is a part of that study. So we cannot take that, we cannot say that my brother-in-law, sister-in-law's uncle's third son is my relative. Well, that's too far away, and that's going to be too many. Then almost everybody's related to everybody. So we say first degree relative. Okay, the first degree relative or next of kin is an immediate relation. So if my wife, my father, mother, brother, sister, son, daughter, if these people are involved in the same activity in which I am involved, there may be a conflict of interest. So that's an important point to understand. Why do we need to worry about conflict of interest? Well, conflict of interest, if it gets exposed, undermines the value of the research findings. It increases the trust deficit in science and healthcare. Doctors need to trust what other doctors publish, and there's a lot of lack of trust and credibility if conflict of interest are not declared. So, like recently, for example, the Harrison's textbook of medicine about 4 or 5 years back, it was informed that all the editors of the group of the Harrison's textbook of internal medicine collectively had earned nearly $11 million from pharma companies they had not declared. So there are about 12, 15 editors, and collectively all of them had got about $11 million. I mean, it doesn't look like a big amount. It wasn't really a big amount, but the fact that they did not disclose it, and the fact that the Harrison's textbook of internal medicine enjoys such a reputation, brought down the credibility of Harrison's textbook of internal medicine, because they said it was expected of these people to declare financial conflicts of interest, and they didn't. And the fact that they didn't means they had something to hide. So unnecessarily, a negative publicity was created about Harrison's textbook of medicine, which was really not needed. And now doctors will have a little less level of trust. I mean, people won't implicitly trust what's written in Harrison compared to maybe 5 or 6 years back. So conflict of interest can occur in research from small things. It could be just a gift from a company to the physician, all the way up to manuscripts can be written by the industry and completely gifted. The authorship can completely be gifted to some big person. So a very busy clinician, the company will come up to him and say, we'll write the paper for you. You simply sign the authorship form certificate and it will be published in your name. So up to that level also, there are various levels at various temptations that can be created before physicians, creating conflict of interest in their mind. So in the case of research, such conflicts of interest may bring bias in the minds of the research and can affect at various levels in the research. Conflict of interest can affect informed consent process. So if I don't tell my participant that there is so much risk because I'm a shareholder in the company, and if the company's shares increase, I get better dividends and things like that. So I might not release all the negative information to my participant in the informed consent process. Similarly, in the decision making, whether to recruit or not, in the data collection, in data analysis, in the hiring of staff members, in the procurement of materials, in the sharing of results, in the choice of protocol, in the use of statistical methods, at every level, conflict of interest can adversely influence the truth-finding nature of research. So conflict of interest can have wide implications or long-term implications depending on how the scenario unwinds itself and what is the research in which is happening. So ethics committee also can have conflict of interest. It might be that I may copy one member's protocol. So there must be a member who's submitting a protocol, and I might copy it and use it for my own study, which is why every ethics committee member signs a confidentiality agreement that he will not misuse the data that is sent to him in confidence. EC member may receive financial support from a pharma company. So one of the members might be receiving some kind of support from a pharma company. So the pharma company may be, let's say, for example, hiring me, saying, doctor, once a week over the weekend on Saturday, Sunday, please travel to different parts of Karnataka. We'll give you a traveling allowance. We'll take you from here to, say, Bidar. We'll keep you in a 5-star hotel. Next day, you have to give a talk to the local association of physicians there, and we'll pay you this much amount, 10,000 rupees for each talk that you give. And every weekend, I'll be taken to different parts of Karnataka. In that case, I have to declare that I have this kind of financial support from the pharma company to the ethics committee. Or it may be my wife's protocol is coming to the ethics committee, so I have to declare the conflict of interest. It could even be a colleague's protocol. Now, colleague's protocol, most people say, doesn't need to be declared as a conflict of interest, but it's a good idea because, as we discuss later on, when in doubt, declare is a good thumb rule. So, colleagues' protocols, if it's HOD's protocol, I must say, look, this is my HOD's protocol. I would like to declare conflict of interest. If the committee decides, if the ethics committee says, yes, please step out, I will step out. But if the ethics committee says, no, we don't have any problem with that. He's just your boss. You're anyway a professor. You're not going to get any promotions. You don't have anything to do with your boss, with your HOD. You can continue to sit. I can continue to sit despite having declared conflict of interest. In publication, there can also be conflict of interest. So a lot of conflict of interest happens there. And therefore, if you find in the end, they write, there is no conflict to be declared by the authors. They give a declaration or a disclaimer at the end in very fine print, it's written. There's a problem. Many of the papers published in the best journals in the world, New England Journal of Medicine is like a Bible for physicians. They found there are research people who research on the papers published in NEJM, and they found that 30% of articles in NEJM and JAMA is Journal of American Medical Association. 30% of articles had one or more authors with conflict of interest. And they also found in the same study that authors with conflicting interests were 10 to 20 times less likely to present negative findings than those without conflicts of interest. So conflict of interest was influencing the judgment of these authors, and they would not publish negative findings. The very famous editor from the New England Journal of Medicine, Marcia Angel. Marcia Angel has written a very damning statement, and I'll put it up here, and I can show it here if you can see my cursor. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. A lot of doctors in the US raise their voice against her, saying that she has a biased opinion. But the fact that for 2 years, for 2 decades, for 20 years, she was the chief editor of the New England Journal of Medicine, and she had to say this, makes us sit up and think, that is the pharma company really controlling how healthcare runs, at least in the US? She's written several books, The Truth About Drug Companies, How They Deceive Us, and What to Do About It. And it's a good idea to read that book. But understand that she's giving only her part of the story. Maybe it's a little biased, but there's some truth behind it, because there cannot be any smoke without a fire. Okay. How do we manage conflict of interest? How would a researcher manage conflict of interest? In his participant information sheet, the researcher must write, I'm getting funding from this institution, ICMR, DBT, whatever funding institution is giving me. So he should tell that information to the participant, saying, I'm getting funds. From this fund, I'm taking this much salary. Or if you're not taking salary, even though the study is funded, the PI is not receiving any salary. You should be able to write that clearly in the participant information sheet. And therefore, you should say, I have no conflict of interest to declare. The researcher will not have any conflicts, and he should declare this in the participant information sheet. He should also declare his affiliations if he has any. The other way of reducing the conflict of interest would be blinding of the study whenever possible. So blinding of the study reduces bias at several levels, and one level at which it reduces it is by handling conflict of interest properly. The researchers should independent data safety monitoring board or other monitoring boards, which will look at the risk and reassess the 6 months for participants in a study. How does ethics committee manage conflicts of interest? Members sign confidentiality agreement and declaration of conflict of interest. Every member signs it at the time of joining the ethics committee. All members, internal members, external members, independent consultants, even if they invited guests for 1 or 2 meetings, internees, students, secretarial clerks, everyone signs confidentiality agreement and declaration of conflict of interest. But what we sign in the beginning is a letter to the member secretary, to the chairperson, sorry, which says, we promise to declare conflict of interest if and when it arises as a part of our review process or as a part of any business activity of the ethics committee meeting. And when the review comes to us and we have the conflict of interest, within 48 hours, we have the time to declare this conflict of interest and return the document back to the member secretary saying, I cannot review this because of conflict of interest, and then give the explanation for the conflict of interest. During the meeting, the beginning of the meeting, the chairperson loudly asks everybody, is there anyone having conflict of interest? And either that person or the member secretary will identify those people and say, here is the conflict of interest for this person for so-and-so protocol, agenda item number so-and-so. And the chairperson says, during that point, please step out of the meeting and we'll call you back again once the deliberation and voting is over. So that's how it's handled in ethics committees. And in the ethics committee approval letter, which goes to the sponsor, they should reflect in that the following members declared conflict of interest, in the discussion of your study, and then we write nil because we don't have anybody in that. Or if there's anybody, as we say, the following person declared conflict of interest and did not take part in the decision making or ethical deliberation process. At the institutional level, all institutions should constitute a committee which looks into conflict of interest. Majority of these members should be external members who have no stake in the outcome of the research. They should set up the institutional ethics committee in a manner that allows it to function independently. There should be training of administrative authorities and staff, and there should be clear guidelines on conflict of interest, which should be put up on the institutional website, saying this is our policy on conflict of interest. There should be a policy approach. The policy approach comes from the government or from, let's say, the UGC or the ICMR or some such apex regulatory body. The approaches are not there currently, but how should one approach conflict of interest? You could have one extreme, which says prohibitive approach. Don't allow any conflict of interest of any sort to happen. But we know that prohibition ensures failure. We've seen the prohibition not working in Kerala. We've seen the prohibition not working in Gujarat. If you want to stop someone from drinking, the best way to ensure that they drink more is to prohibit the sale of alcohol and make it a dry state. So this prohibitive approach is likely not going to work. The other extreme is don't worry anything about conflicts of interest. Just leave it and don't have anyone declare. Then people have got financial interests and so they don't declare. It will reduce, it will cause a trust deficit between scientists and the community at large. So both extremes are bad. We have to find an Aristotelian golden mean somewhere in the middle, and it's called a pragmatic approach. Let's understand that conflicts of interest are here to stay. Let us try to encourage voluntary declaration. We should try to minimize it rather than trying to punish everybody. So punishment should be in rare instances. And we should have a clear definition that, okay, if it's financial conflict of interest, definitely should be declared. What should be the amount beyond which it should be declared? We don't have, in the US, there's a clear policy on this, $10,000 US and more in the annual year, in the financial year, if a person has earned, it's considered as significant from a company and he has to declare financial conflict of interest. But in India, we don't have any such cutoff. So underlying philosophy should be, as far as possible, declare the conflict of interest. Let others judge you. If you have nothing to hide, they will judge you well. The thumb rule is, when in doubt, declare a competing interest. Just don't worry about what will be the consequences. And that's the standard teaching in ethics. When in doubt, declare the conflict of interest. Similarly, we have, when in doubt, submit to ethics committee. It's a similar thumb rule. The researchers will think, oh, mine is a study with just a questionnaire. Should I submit to ethics committee? When in doubt, submit your protocol to ethics committee for approval. Let ethics committee decide that this is exempted. They'll write you back a letter saying that we went through your study, it is less than minimal risk as per the ICMR guidelines, and your study is exempted from ethical review. That letter, which you keep carefully and safely, will act like an ethics committee approval letter if a journal asks you for it during the time of publication. So it's a good idea to let it go to ethics committee, let ethics committee write back to you saying, no, we think this is exemption. Rather than the researcher himself assuming that this is a minimal risk study and I don't have to take ethics committee approval, I can go and do the study. But tomorrow when the journal asks for the ethics committee approval, and then the researcher comes to ethics committee and says, give me a backdated ethics committee approval, that can't happen. So we don't give any retrospective approvals, it's only prospective. So hiding competing interests hints at dishonesty is what Smith and Blesby have written in the British Medical Journal. Raising doubts about the integrity of what has been written or said. You may not have any problem, you may not have any dishonesty, you may not have anything, but the fact that you hid it from the public, and once it became known to the public, it makes people think because he had something to hide, there must be some issue in this. So it unnecessarily spoils the credibility of the researcher, and eventually is going to lead to the reduction in the credibility of the science as a community as a whole. So I'll just take you in 5 minutes, if you permit me, through the case of Jesse Gelsinger, where there was a lot of conflict of interest. Shivanand sir, is it okay, or do you want me to stop?
Okay, sir. 5 minutes should be fine, sir. Yeah.
Okay. Sir, can I continue?
Yes, sir. 5 minutes should be fine, sir.
Yeah, fine.
It's okay, sir.
So Jesse Gelsinger is the first person publicly identified as having died. 1 minute. No, it's okay. Yeah, Jesse Gelsinger is the first person having publicly been identified as having died in a genetic clinical trial. He was suffering from ornithine transcarbamylase deficiency, an X-linked genetic disease of the liver, the symptoms of which include an inability to metabolize ammonia, a byproduct of protein breakdown, which ultimately leads to hepatic encephalopathy. Gelsinger had a mild version of the disease. Some of his liver cells were normal, therefore enabling him to survive on a restricted diet and special medications. Gelsinger was recruited in a clinical trial run by the University of Pennsylvania that aimed at developing a treatment for infants born with severe disease as a last-minute replacement for another patient who walked out. So he wasn't meant to be in the trial, but the trial was meant to be for severely ill patients. Jesse had a mild disease, but the 8th person who was being recruited, because they had a sample size of 8, the 8th person who was being recruited suddenly walked out, and at the last minute they took in Gelsinger, even though he was a mild case. The clinical trial was experimented on monkeys and 2 had died, but this information had not reflected in the participant information sheet and the informed consent form. So all the 8 members who registered, including Jesse Gelsinger, did not know that in the animal experimentations, 2 monkeys had died. The scientists involved in the trial, including the co-investigator Dr. James Wilson, who is the director of the Institute for Human Gene Therapy where the study was being carried out, had financial stakes in the company manufacturing recombinant DNA used for the trial. These facts are not reflected in the participant information sheet and the ICF. So clearly what we have here is a problem. In the participant information sheet, the PI did not disclose his conflict of interest, did not disclose his affiliation and income, and did not disclose information that there was risk because they used to transport the gene into his cells, leading to multiple organ failure and brain death. So that is the case of Jesse Gelsinger. It raised large debates in the US about conflict of interest declaration and how can systems be tightened to make researchers voluntarily step up and declare conflict of interest. But it didn't lead to any further strengthening of the guidelines because it's still left to, it works on the assumption that every researcher is honest unless proved otherwise. So that's the principle on which it works, and therefore they say, if he's got something, he should declare it, and we expect him to declare it, so let's leave it as it is. That's the current position at conflict of interest. So summarize, conflicts of interest are here to stay. We can't throw them away, we can't get rid of them. So let's encourage declaration rather than trying to block them. Let's create mechanisms that encourage people to declare conflict of interest. Let us minimize the conflict of interest by saying that non-financial can be overlooked and financial can be reported. At least institutions should be seen to be taking steps to minimize conflict of interest. There should be ensuring of safeguards and monitoring. Wherever required, corrective actions may be taken. So that if the financial conflict of interest of a death occurs and the conflict of interest is brought to light, then some definite corrective actions should be taken in such situations. Thank you very much. That brings us to the end of our presentations.
Okay, sir. I
There are any
thank Dr. Umakal Karni and Ravi sir for their excellent presentation. Now we have the next presentation from Dr. Pratibha Pereira. We'd like to introduce her again. Dr. Pratibha Pereira is currently working as a professor and head in Department of Geriatric Medicine, JSS Medical College, Mysuru. And she has been instrumental in development of standards for accreditation of ethics committee by NABH accreditation. And she also chairs the technical committee of NABH for accreditations. And also she is the principal assessor for NABH accreditation. She has several publications in reputed national and international journals. And also she is presently the member secretary for CDSA CCRE in our JSS hospital. Thank you, ma'am. And it's over to you. You can continue with your presentation.
Yeah. It's the topic is very tough, yeah. GCP, and to take it through, it is difficult. And they have 2 days. They have exercised your vocal cord. I listened to many of the sessions also because GCP is close to my heart, and some of the sessions were very, very good, very informative. So I'll share my screen now. Okay.
Yes, ma'am.
Now, what I'm going to take to is nothing with respect to GCP. It's just that the GCP will close with going into regulations. So any of the regulations is akin to. So I'm just going to go through it. I'm closing in with what Dr. Vaswani was saying, because all ethics committee members sitting there need to understand that you have to get updated, because GCP is inbound into the regulation, and how does the regulation matches this. Can you see my slide? Okay. Now the background is...
Yes, ma'am. Yes, ma'am. Can you just make it full screen, ma'am?
Yeah, sure. I'll make it full screen. Okay. Now visible?
Yes, ma'am.
All right. Now, I want the EC members to understand that earlier clinical trials were conducted under the...
ma'am, it's still not full screen, ma'am.
It's not full screen, but to me it's full screen. For me, there's full screen. I think I just go through.
Yeah, okay, ma'am. No, go ahead, ma'am. Not a problem.
All
Please,
right?
ma'am. Yeah, sure.
So it was as Schedule Y. It is, they should know that GCP and everything is intertwined into regulations. So it is, the earlier regulation was Schedule Y, and it was under Drugs and Cosmetic Act. And mainly this is brought about for patient safety and compensation. That is what you've been listening to yesterday and today. How do we address patient safety and compensation? Patient when it becomes a subject. That is what I want to tell you. And they were not very happy with it. So in 2013, they added 2 rules. You have been hearing compensation. So they brought in a rule called 122 DAB, that is compensation for care of injury and death during the clinical trial. And so here they added financial compensation above free medical. I was looking at Dr. Vaswani's presentation. He told you calculation of a compensation. Now that is how much are you going to give him apart from the medical care. So whatever rules happen, that sometimes it gets reflected to GCP. There may be a delay in getting reflected to GCP, but you will have to update yourself what's happening in various areas. So next is 122 DAC. They brought that rule, which was basically they sort of tweaked in the EC approval process. That's when the CTRI registration came and submission of SAE. Some more details into submission of SAE, which they have taken. I'm not going to go into that. Now came, after following the Schedule Y, we now have what is called as new rule, new drug clinical trial. Now this is the rule you will follow. All of you can go into the website. You're going to get the full thing about new drug clinical trial, where whatever Dr. Vaswani and the team have said is interspersed as regulation. So this contains 13 chapters. I'm only highlighting, which is very, very important for EC members to look into, because you have to follow the regulation. Now, chapter 3 is Ethics Committee for Clinical Trial BAB studies. They tell in detail what do they need if you're doing clinical trial, how should be the ethics committee, what are the members, what is the representation, every detail is given there. But interesting is that introduced one chapter 4 as regulation, that is ethics committee for biomedical and health research. So to all the EC members of dental college, all your biomedical research also indirectly has come off into regulatory gamut. So you have to follow whatever they say. As per these guidelines, the ethics committee for biomedical and health research, you have to follow ICMR guideline. GCP is kind of same for both, but some of the guidelines for your biomedical research, you have to get trained in ICMR guidelines and you have to follow ICMR guidelines. Now, chapter 5 is approval timeline for EC, status report, and independent. Ethics committee members, you have to know that if you are approving a clinical trial and you cannot just write one statement and say, don't approve, they have said that it has now become a regulation. So it is not only in GCP, but it is put in chapter 5 of NDCT. So when you're giving a not approval or whatever, you have to completely give detail. Then there is another extra for status report. You have to ask status report. Yes, the sponsor gives status report to the DCJ, but you will have to ask your investigator to give you the status report. And if there are any investigators, coordinators sitting over here, you have to give status report to the ethics committee. That's in chapter 5. Now, very interesting point is given about independent ethics committee. We are an institution. It doesn't matter to us. But they have said, okay, you can have an independent ethics committee. Why this is important? Suppose you don't approve a study. The PI has every right to go somewhere else for an independent ethics committee. If you don't give him proper explanation why you have disapproved. But that independent ethics committee should agree and say, okay, well, I'm prepared to come and monitor the study. So that is one extra they have given. Now, I've left the chapters which is not important for EC or for coordinators or for PI, which is for sponsors, I have taken it out. Now, chapter 6 is detail of compensation and death and injury. Here, regulatory wise, they have made one important difference. That is, earlier it was either the reporting timelines were when it happened. But sometimes, it happens and the people don't even tell you. So you can't keep the timelines of 14 days or 3 weeks. It was becoming difficult. So regulation is when you come to know of it. So when the PI comes to know of it, that is the starting date. And when he tells EC and EC comes to know of it, that is the starting day for EC. So when you're addressing SAEs, compensation or injury, just know that there are some definitions that has changed in these compensation. The rest of it is perfectly what Dr. Vaswani, they're not changed all right. Only the definition and bit of... Okay, done. So as I was saying, chapter 3, I think what I said you would have followed. But remember, for ethics committee, you are involved with PG students, PI initiated study. Please read chapter 4 of new drug clinical trial, where they have told what you should do, and they have only made one blanket statement that if you're approving PG studies or anything, you have to follow the ethics committee composition of ICMR guideline and whatever ICMR guideline says. So that's one important thing you should follow. For any clinical trial, it is new drug clinical trial. Now, chapter 5 is approval timeline. As I said, that ethics committee, you have to give a detailed letter saying why you are disapproved. Otherwise, they have all the right to go to an independent ethics committee, and your postgraduates or whatever have to give regular status report. That's important. Now, chapter 6, compensation, I told you that when you come to know, that is the starting date. Because, they taught you about how you have to report essays. So from the day you come to know begins your 21 for ethics committee, and for the PIs, the day you come to know begins your starting day. But immediately you will have to tell the sponsor. Now that is important. Now, in the second part of new drug clinical trial, you have something called as schedules. So you have chapters, you have schedule. Remember, chapter 2, chapter 3, and chapter 4 and chapter 5 are critical for you all to understand. Biomedical research, PI initiated studies is under the gamut of regulation. You have to follow and get trained in ICMR guidelines. Now, schedules are, there are second schedule. I'm only going important, which is a schedule that is linked to GCP. Now, second schedule is they have brought in accelerated approval, expedited approval. You can do it. That is what everybody did in approving of clinical trial for vaccine trial. And also DCJ approved and gave it emergency use authorization. Here our ethics committee approved. What do you mean by expedited approval? Means you don't go for your regular agenda once in 3 weeks and then only I'm approving. It's not like that. So you hold an expediter, so you can make an SOP, so they're given provision for that. Something very, very urgent, you can do it right now. Now they've given good importance to investigators brochure. So they have given some details, that investigators brochure, please read it, and detail of prescribing information. So whenever a drug trial comes to you, please see that whether the prescribing information is as per the new drug clinical trial, is the sponsor following it or not. BABE, important for pharmacy people, not for dental, that's okay. Fifth, this is again, I want to tell you, is they have brought new regulation for post-marketing studies. I think they must have taught you about phases of trial yesterday. Phase 4, they have divided into PMS actually. PMS means post-marketing study or trial, then post-marketing surveillance. So be very careful of this protocol that is coming to you, because what the regulators are saying is, if they say it is post-marketing study, then you should do it exactly like a clinical trial. But if it is just post-marketing surveillance, then you don't need to go into the detail of compensation and everything as in a clinical. Earlier, what they used to do, oh, this drug is marketed and we don't have to do anything. But now DCJ is very, very careful. They're strengthening pharmacovigilance. So all PSURs are taken very seriously. Based on the PSURs, they will plan the surveillance. So heading will be there. Post-marketing surveillance or post-marketing study or trial. If it is post-marketing study or trial, they have to do it like a phase 3 trial. So that is one more regulation they have brought in. Now they have brought new definition. They have already taught you the new drug. I just want to tell you is all drugs which are marketed for 4 years, they're still called as new drug. That is why post-marketing study is very, very critical for you all also. Device or drug. So be careful of this post-marketing study, and they will be called as new drug even after 4 years when their safety is proven in the community, it is taken up. Of course, vaccines, biologic, they always remain as an adverse event. I think yesterday I heard the EC member taking up adverse event. She clearly said all lab errors, everything is now taken into it. Then they have said clinical trial, they have brought into the definition safety, efficacy, and tolerability. They have brought into that definition phytopharmaceutical they have given, which will be important for you all dental people. Look at the definition. Now, interesting is they brought a definition called as academic clinical trial. What does this mean? They have defined it as any PI can bring in a project and say, look, I'm using this for a new indication or a new formulation. It is not there in standard of care, or it is not there in large meta-analysis. They become academic clinical trial. Now, do you have to submit to DCGI? That is prerogative of ethics committee. When do you call academic? I have no financial interest. I am not selling this product. I'm only doing it for my interest. So that is called as academic clinical trial. So EC members, when they come to you, study it nicely. Are they doing new indication or a new dose? Then it is called as academic clinical trial. Onus is on ethics committee to assess it very critically and see, is this a safe study or does it come under the definition of academic clinical trial? So I'm not now biomedical. Why they have defined it is because it is come under regulation chapter 4, chapter 3. So basic applied operational research appealing, everything comes now under regulatory gamut. So you have to be very careful that OPI, PG thesis, this thesis, no, it is under regulation now. I'm not going to go to independent ethics committee. This also I told you, when ethics committee disapproves, you have to give the reasons. Otherwise, they can go to DCJ and say our ethics committee is not approving. So when we talk about academic clinical trial, you get confused, ethics committee member. Don't worry. You're in doubt. Send it to DCGI. Look, this is where it is. This is a new formulation. Because in new drug definition, I think Dr. Vaswani must have told you the definition, that new formulation, new fixed dose, individually it may be marketed, but they've all come under the gamut of new drug. So you have a doubt, write to DCGI. We are having a project from a doctor or someone here, new drug or new device. We don't know whether this should be considered as clinical trial. Can you let us know? They will help you out. So this is the crossover that they have brought in, and I'm not going to go into this again. See, because this has been told. Again, phase 4, I clearly told there only what is the difference between post-marketing study, post-marketing surveillance. Now, there's a little bit of difference in medical management and compensation. In a clinical trial, yeah, everything done. Academic clinical trial, you go as per ICMR guideline, but in ICMR guideline also they say compensation is there. So not all PI initiated study can be just passed off and say no compensation. You have to study it properly. Even biomedical health research, look at both ICMR guideline, BAB study, medical management compensation, yes. Phase 4, yes. Earlier phase 4, no compensation, no medical management. It can't happen like that now. Again, there is compensation and this thing as per new regulation. So it is very, very important. Now for you, dental committee, you do both. So you have criteria, you are doing clinical trial as per our regulation, more than 50% must be from outside. In biomedical research, ICMR doesn't put any such criteria. For quorum, a clinical trial doesn't put any criteria directly, but biomedical says more than 50% of the members need to be there to fit the quorum. And in that quorum, of course, 5 important persons, which they have taught you. Now, selection here, they say you're doing clinical trial, at least one woman should be there. In your biomedical research, no such criteria. Training is there for both, but for biomedical, you have to get trained in ICMR guidelines also. Validity for registration of PC is 5 years. One thing is you're doing clinical trial, you will go and get registered in BCJ, but if you're PG thesis, you have to get registered for both. So your EC, you have to get registered for both. You can't say, okay, BCJ, I don't have to do this. That does not happen. Independent ethics committee both agree, that's okay. Record keeping for clinical trial it's 5 years, but here it's as per the study and as per the guideline. So I have just brought out certain aspects of GCP, which is very, very important for you to understand in your functioning, because GCP regulations go together. EC members, keep updated your training session on regulation. So every time go to their website. Every time you have to go to the website and keep checking what are the new updates, notifications, all that is there. So I have closed it up. Thank you very much.
Thank you very much, ma'am, for your excellent presentation. So thank you all. So now hereby request the delegates, if they have any queries or any questions to the resource person, you can put them in the chat box. So in the meanwhile, I would also hereby request our beloved IEC member, Dr. B. Nandlal, who can just give his feedback regarding today's presentations. So delegates, in the meanwhile, please post your questions or queries in the chat box. Thank you, sir.
Very good afternoon, Dr. Shivanand. At the outset, I would like to say special thanks to all the resource speakers who have been sharing their long-term training, which they have and practically try to see what the problems are in the ethical boards. And my special thanks to Yenepoya University for extending this excellent resource persons for us from their Center of Ethical Committee. Please convey our greetings and thanks to the management committee of Yenepoya. And to summarize in short, I would like to we recall that our first speaker, Dr. Uma Kulkarni, had highlighted on the informed consent and the role of institutional ethical board. Because many a times we think it is just a part of the annexure which is to be there, and we need to look at its presence. But the way systematically we have to look at it and make sure that whether the patient has been very, very clearly explained, the information sheet, and then also the documents of all the documents regard to documents regard to the screen, having the information of whether the patient is given the equal opportunity and he knows about what is going to.
Sir, your voice is breaking, sir.
Sorry,
Your voice is breaking, sir. Yeah, now it's fine.
is it okay now?
Yes, sir. Yes, sir.
Yeah,
Bunny,
yeah.
sir.
So,
Yes.
so besides that, including the information that whether the researcher has going to conduct the study sampling at his own center or he has to visit, and how the patient is going to be managed during the visits here, and again according to the informed consent about the age way to consider the different formats of below 7 years and 7 to 12 years in adults, and both verbal and written and electronic concerns were addressed very well. I'm sure the message is undertaken by all the new researchers as well as ethical board members, which it's become mandatory now. The informed consent form has to be reviewed with a much more serious note than just we take it as one more annexure requirement, because many a times patients do not really understand, though we try to. They say that they are included in the project, they have the benefit of treatment, or whether it's a benefit of therapy, but the other like particularly compensation of the wages as well as the travel allowance is not mentioned very clearly to them, and whether that should not be the only incentive. Many a times that is considered as one of the motivation, which is only a secondary, I would say. The next speaker, our Dr. Vaswani sir, Professor, Department of Internal Medicine, has again highlighted the responsibility of the stakeholders, both sponsors, monitors, and investigators. It's a very well taken message, sir. The monitoring part has been taken very, very light, I would say, and some of the times the PIs do monitor, but here, the concern of having a special monitoring person who is well trained and is also to do a check, and what are his roles, what is the SOPs to be followed right from the time of whether the design and is implemented, recruitment and the stocks and the medication, which has been time to time, and reporting as a link between the researcher and to the sponsorer is well taken. And I'm sure this will be taken in a much more serious note by all the clinical trials to make it sure that it is not having any lapses in between, and finishing in time. That's the recruitment in time also is very thing. Like we at JSS have had some of the projects from international funding pharmaceutical companies, and even at the dental school, we had a real, I would say, exposure on these aspects. Monitoring, site monitoring was very much taken, and all these points we felt it's really very essential to make sure that studies are completing within the time frame which has been made for. Otherwise, the study of 1 year would become a 3-year study, and keeping various reasons. So, and these SOPs have to be very much well defined, and the role of a monitor has to be incorporated as one of the serious note. I would thank you, sir, for this, for such a wonderful area, which is very much sensitive and the need of the time today, with so many clinical trials coming to India. And coming to the next topic, again by Dr. Uma Kulkarni, the privacy and confidentiality. Madam, it's very essential as some of our dental faculty and students who are also involved in now related medical research, dealing with HIV patients and oral conditions, and even COVID symptoms now, patients coming. And as you rightly said, we have a habit of communicating among the groups, and this confidentiality has to be, and privacy is very essential, and maintained with confidence needs to be followed. And I'm sure that our members and delegates have taken it for also important aspect, and compile with that. Lastly, the next topic, which was again addressed by our Dr. Ravi Vaswani, on conflict of interest. It's a very, very sensitive, again, as we know, both as a team member or as a faculty. It is, as we all have to declare, it is mandatory even in a publication, as you have rightly said, sir, that we need to declare the conflict of interest even in the publication, whether it is of funding or by if any other monetary consultancy has been offered. And I'm sure this type of conflict of interest, once declared, and if the amount is within the framework and he's blinded and that's how you the suggestions you made on as per the ICMR guidelines and other guidelines. How do we manage this conflict of interest by blinding and keeping the confidentiality and revealing it right in the beginning without any hesitation? It was well taken, sir. I'm sure this will be followed by many of the researchers who are very much engaged in the areas where there is a consultancy along with that. And also, our speaker from JSS, Dr. Pratibha, has highlighted very importance of the competence of the compensation and the way we should deal with the new drug or the post-marketing studies, particularly we taking into the phase 4 studies, and also the highlight on whenever necessary, we should take help from the DCGI is well taken. I thank you, all the speakers on behalf of the JSS Dental College for having given us a wonderful 2-day program where I'm sure our researchers are much more both as a research conductors, a research engaging in various clinical trials, and as an ethical board member, what are the areas we need to really focus and ensure that it is taken care of. I thank on behalf of JSS Dental College and Hospital and JSS HER once again for giving me this opportunity to share and summarize the speakers, resource persons who have shared their wide experiences in the ethical committee and from the vast knowledge they have gained over the years. Thank you.
Thank you very much, sir, for your extensive feedback on all our resource persons. So I thank once again all the resource persons for their tremendous work they had to do for these 2 days. Now I hereby request our respectful chairman, Dr. Vishweshwara. Sir is the chairman for our JSS Dental College and Hospital Institutional Ethics Committee. I hereby request him to kindly say a few words and give the closing remarks. Sir, can you please unmute, sir? Vishweshwara,
Yes,
sir?
yes.
Yes, sir. Now we can hear you, sir.
So first of all, good afternoon to everybody. From past 2 days, it was academic feast for everybody, especially clinicians who are practicing in clinical trials and things like that. I would like to say that from past 10 years, we are very much exposed to clinical trials, and today the clinical experts have brought into threads and bears of the clinical trials. How do we take the trial? What is trial violation? And as Dr. Professor Nandral said, each and every topic has been taken in a very detailed manner so that the both should be benefited. Patient is also benefited, and the knowledge is also given to the corresponding researcher. So there should not be any kind of loss or any kind of this thing should not happen, and the researcher should not get into trouble. So if we follow our documentation, our communication with the patient very well, and definitely the trial should be a successful one, so that would give us a further further light to treat such patients, whether it is post-marketing, as Professor said, and the phase 4 trials, or otherwise which is involved in phase 3 large trials. So it is a very important aspect for a student, which when we were students, it was not at all available. Now with this thing, hard efforts of our secretary, JSSDCH Ethics Committee, and all the best of the faculty who are already involved in clinical trials have given their best tips so that we can conduct them and get involved in clinical trials safely, both for the patient and as well as for the researcher. So I wholeheartedly thank everybody, sir, and I wholeheartedly thank especially the principal, vice principal, and our secretary, Dr. Shivanand, has taken a lot of pain in doing so. And apart from all our the outside faculties from Yenepoya, and also Professor Pratibha from JSS Medical College also, they've all given their knowledge bank to everybody, and we're all indebted to this. And once again, wonderful compliments, and I thank them for again making us to understand these things in a better fashion. So thank you, Shivanand. This program was
Thank you.
really wonderful to one and all.
Thank you, sir. Thank you very much for your very encouraging and words, sir. So now I hereby request our beloved Vice Principal, Dr. Chandrasekhar, so to kindly give his say few words.
Thank you very much. Good evening, all. I especially would like to extend our sincere thanks with gratitude to the resource persons of this workshop from Yenepoya Dental College and University. They have selflessly accepted the invitation and they have spared their valuable time. We know how busy they will be. Despite their busy schedule, they have spared their valuable time and shared their valuable inputs, also expert inputs. We are confident that the IEC of JSS Dental College and Hospital will definitely put into practice whatever that has been deliberated and learned over the last 2 days. One sincere request to the IEC of JSS Dental College and Hospital is to percolate this information to the PG students and faculty at the institution. Whatever that is learned in this workshop by the IEC members over the last 2 days, I request them to organize a small scale workshop for the PG students and the faculty at the institution so that the information gets percolated down the line in the institution. And that is how we would like to translate whatever that has happened in the last 2 days into reality. I definitely am very confident that whatever that has been deliberated upon will be put into practice at the institution level. And I sincerely extend our thanks and gratitude on behalf of the institution to all the resource faculty, Uma Madam, Ravi Sir, and Pratibha Ma'am, as well as other resource faculty, as well as the delegates who are attending this program. Thank you very much. I am definitely confident that this was a fruitful workshop. The way the feedback was given by Nanlal Sir and Chairman Vishweshwara Sir, that only reflects how good the workshop was. Thank you very much.
Yeah, thank you, sir. Now I hereby request our Honorable Vice Principal Sir and our Chairman Dr. Vishweshwara Sir to kindly give away the certificate of honor to the resource person. So
thank you, Veena Ma'am. I missed your name. Sorry for that. Thanks a lot for your valuable time.
Yeah, Vishweshwara Sir. Sir, can you please unmute, sir?
Yeah, I'm here, sir. Yeah.
Yes, sir. So she's our next resource person. Yeah. So thank you, ma'am. Thanks a lot. And here we show the gratitude to you. So thank you very much for.
Thank you so much
for accepting, and in a short while you have delivered a very good talk. So thank you, ma'am.
Thank you so much.
And next person is Dr. Ravi Vaswani, sir.
Sir, thank you, sir, for you have brought in all the nitty-gritties of the clinical research points. So definitely each and every tip will be taken from you. And in future, anything regarding this, we'll request you to guide us also. Thank you. Thanks for the same. Thanks for your participation in this program. Thank you. Thank you.
Yeah. Next is Dr. Pratibha Pereira, madam. So thank you, ma'am.
Madam, thank you. Thank you, madam, because of your interest and you have shown us and given your valuable tips in this regard also. So we wholeheartedly thank from the Department of JSS DCH, our ethical committee, on behalf of our president, secretary, and principal. Thank you, madam.
Yeah. So I thank our chief guest for the function, our respected registrar, Dr. Manjunatha B, who presided over the function yesterday. Thank you very much, sir. So I would like to thank the guest of honor for today's this program, our beloved Kushalappa sir, Director for Academics. Thank you very much, sir.
Thank you, sir.
So I would like to thank our beloved principal for all his support and help in order to organize and conduct this workshop. Thank you very much, sir. And also would like to sincerely thank our Vice Principal, Dr. Chandrasekhar Bihar, for his continuous support and help in organizing this workshop. So thank you very much, sir. I thank all the members of our JSS Dental College and Hospital Institutional Ethics Committee, our chairman, sir, Dr. Nandlal, sir, Dr. Manjunath, sir. Then we have Dr. Jayanti ma'am, Dr. Praveen Kulkarni, the Kumudini Achi. Then we have Nagendra Murthy, and also we have Adesh. So I thank all my respected and dear members for attending this GCP program and making it a success. Thank you one and all. So I hereby thank the organizing committee. This is Dr. Girish from the Department of Pediatrics, Dr. Vidya from Department of Pathology, and Dr. Deepa from Department of OMFS for their support and help in order to conduct this program. And I thank all the delegates for attending this program and making it a grand success, without which our program wouldn't have been so successful. So thank you each and everyone for registering and attending this program. I humbly thank the information and technology department of JSSA HER for their relentless support in right from making brochure till the validatory function. They have been with us in order in structuring this and conducting it, and all even making certificates and everything. And my special thanks to Dr. Sumuk for doing all the needful job what needs to be done. So thank you, Sumuk. Thank you.
Thank you, sir.
So thank you one and all, and my sincere thanks to Yenepoya Ethics Committee 1 unit again, and also the JSS Hospital CDSA CCR unit for their extensive support and help in order to organize this program. Thank you one and all.
Thank you.
Sir.
Yeah.
Two quick points.
Yes.
One is we
Yes,
request all the participants to fill in the quiz and send it back to us, because we need to have an assessment of how well they've understood what we did, and the GCP certificate will be given only on the basis of how they score. They can take the quiz again and again. It's
Sure,
time that they get a score of 15 out of 15 answers correct out of 20 is 150 out of 200. And
Sure,
the second request is that there's a feedback form that we'll be sharing with you in the next 1 minute or 2 minutes. Ask them to fill that up, also give back to us.
Sure, sir. Sure, sir.
Google form.
Yeah.
Thank you so much.
Sure, sir. Sure, sir.
Thank you.
Nice meeting you all.
Yeah. Yes, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank
It
you,
was a
sir.
very, very nice meeting. Very nice meeting.
Yeah.
Technology has
Thanks,
brought
sir.
us all together, even we are at distances. Definitely, thanks to this Zoom technology. Thanks
Yes,
to
sir.
everybody.
Yes, sir.
Bye.
Sir, we shall also circulate your MCQs and feedback in our
Please.
WhatsApp groups and also email IDs,
Please.
so
Please.
that no registered participants or attendees are missed out. So we'll
Sure.
make sure that all of them give the feedback as well as the MCQs, sir.